And they go, and they, oh, it's the people that get, because the people get, the businesses involved in it's just for the there's nothing.
So again,
and I would say, like, next week, probably we'll have a better neighborhood. What happened 2 weeks ago? And then we start close.
everything will settle down.
Right. Doors locked. Morning, Nancy. I can't talk to anyone. This is. Hi, Marina. Marina, I am like, that was my guess. How are you? I'm good. How are you? I'm good. Oh, thanks for coming. You know, like my dad and the twin person. Yes. It's like a lot of work that you guys do together. Well, thank you. It's been a good partnership.
We had some fun. Hey, you didn't hear, October 19th, long-term report is being released nationally by Brookie.
Oh my God, that's so awesome.
There's going to be a national webinar.
Oh,
Marina and I will do the dog and puppy show.
oh, that's so awesome.
Oh, well, yeah, the whole advisory committee will get an invitation.
Yeah.
But Brookings is putting it up on their website and they're hosting the webinar. And they're writing the forward to the report.
Awesome. Oh my God, and not only me.
What?
Not only me that I really appreciate all your work. Check and make sure it's going.
Yeah,
No, so I'll just show you.
It should, yeah,
You
because
just
this is a PDF.
You just press right and
Yeah,
left.
okay, perfect.
Yeah, yeah.
Because
These things, the other day it was kind of, you know what, technology is always the X factor, so it's always good to check it.
yeah, I'm like, well, I better just make
Even
sure.
though I checked this out yesterday morning and it was going to be, and then all of a sudden I was like,
What?
literally 2 minutes. I was like,
I know.
that was my speed. Why would people standing in front of me?
There's so many variables.
I know there's too many there. And what happened was the guy who was from the hotel here, like, over there, there's and then when he did that, he just gave it to mine. And I didn't know.
And you have
Oh,
no
yeah, I was,
Yeah, like, why would I
I had,
just
I was gonna make it.
Right, yeah.
Yeah.
Actually,
Yeah,
well, at least we're gonna figure it out.
yeah, and luckily Louise was like, Louise was supposed to talk in the opening.
Today, so I had to get in.
Oh,
Sylvia, and then I was gonna say, I'm really sorry. Luckily with no background.
I lamented.
Yeah, I know.
I have faith for it.
Yeah, exactly. Everyone is had that Zoom meeting.
Yeah.
It is.
One taking care of in front of I'm very sorry. Every meeting. I'm like, I'm sorry. What do you mean?
I know. I wish I had done the same. I mean, there's some breakfast here. Like,
Oh, no, I'm good.
they go to make yogurt and make coffee. Yes.
Did you drive? You did.
I ended up driving. They got the car somewhere that they told me. It took us 20 minutes of the night.
It's better to under promise.
Right. So the UIC wedding ceremony in 2021 was here. So I actually came here from my experience after she doesn't have a position right now, so she asked me.
Ah, okay.
So I came here, it was nice, you know, the next moment, the family,
Yeah.
So look what just came out. I'm so excited. It's Sylvia, me, and Dick.
Oh, wait a minute, I didn't even see the doctors. I was looking at the title of the camera. Oh my goodness.
Yeah.
Wow, that's exciting.
It is.
Where did this come up?
It's on the NPC website. It should be on the forum website, but I won't hold it.
Well, this is awesome. Congratulations. I mean, and also, like,
What?
there has been no
Just
great
give us
resignation.
Oh, thanks.
Oh, well, milk or cream.
Whatever.
I've worked with what I have. So
Good
I'm
morning.
so excited.
Oh. I appreciate that. It's an honor to be with you.
Oh, no, I think I'm.
I'm not ready yet.
Oh, thank you.
Hey, can we do a shameless plug for a new piece that just came out? The Great Resignation is not due to Latinos in Illinois. Latinos are not causing.
You're working on the line. Yes, that was a national report.
It's a shameless.
That's fine,
Good.
right? Like, let me.
Yeah, I like the direction. That's something.
Just.
Yeah.
I think it's
I
live.
still do QR codes.
Do
and I
you-
don't know what
But
to
it
do.
is live.
Because it was.
I did message. 217.
Yeah, so I'll put together, while I'm sending you, I'll put together the most.
We have a
QR
chat.
code, and I'll send it to you. Oh, that's up.
Why would you?
Right, we don't all.
Yeah, I said I feel that.
And I just want my question.
I don't think it matters.
Yeah, they're talking about.
I said, that's just.
But the kids are leaning
Oh,
on
this
this.
is so exciting.
Yeah, if you wouldn't mind telling me.
Now I said,
You do, I don't know why.
Yeah.
Oh, yeah. Yeah.
No, it's Star Street.
But it was a lot.
You know, in the sense.
So here's the thing, is like our mouth, so when you tell them you received it, like you said you received it, but it didn't say that you received it in your job. I'm gonna actually write to them and see what like this is. How it will play.
I kind of like the first
Very sad.
Oh, that's good.
But that you school now.
Except that it's like that.
Yeah, I never played.
That's why those faces. Androgynous. I can't find these pictures.
This morning I was drinking, I just heard the murder rates. It doubled in Lincoln. Oh, I know. Oh, you know the price. Yeah. Well, and also the supply has been tight. So they should be.
Oh, yeah.
Yeah, they had my pancakes. Well, I didn't see pancakes today. Well, they went there. I had bacon. Basically just had, I basically just had a go back and get some. I basically just was like a plate of bacon. And then I was like, I'll have a banana. Go back and get some bacon. That's what I was thinking. I was like, I'll still go around. Like this. Yeah, exactly. Go back and like get more extra. That's actually really good. Maybe I'll like do a second round. Right. I think mine's. I actually brought mine down. So like when actually maybe like whenever you go get second breakfast, you just go grab the stuff. And then let me know. I'll go and make sure we check out. And I think I have to give my card again. I'm not sure. And it was I did a terrible job. I was like, okay, like this material is fabric. And it's so much. I was like, correct over it. And I'm in it was like, I don't care. Is this cool? That's cool. I like it. I like the sleeves. Yeah. But you like if you have one that fits properly, you're like, I'll just get whatever. Yeah. Yeah, because they don't fit. Yeah, so just like if one of the cells just run upstairs with the stuff and then let me know and I'll go down and check it. Yeah, and then we definitely have a second snack. Oh yeah. Testing. Oh, yep. Sorry, testing the mic.
Okay, yeah.
If we could have the presenters up here so that I can just make sure everything's working. No rush. I just want to make sure we have everyone sorted. Do you have yours on a USB? Okay, no worries. I'll put it on the USB.
Okay.
I wasn't sure if you had that.
I didn't bring one yet.
It's fine.
Okay, thanks.
Yesterday was meant to be free, but I'll use my little mini hard drive instead.
Yeah, there's no formal like place. Of course, my clothes there. Right, that's a session.
They should be up there, yeah, everything's up there, the only one I don't have is the chat. Oh, yeah, I did. I can send that to you. That was it. Okay.
It's okay. Yeah.
You're not gonna get started off with that. There's no way. It's not long enough.
So now I'm talking about that, sorry. I went down and asked because I was like,
All right, but I think you should get started.
yeah, just give me 2 minutes. I can go my back.
Okay, so I'm gonna walk to the breakfast area.
Yeah, that's a good idea. No more eating. Yeah. Just so you know, I'll show you the 5 minutes when there's 5 minutes left, 1 minute when there's 1 minute left. That's this.
Get out.
The red, the scary red one. But just so you know, I'm flashing it up red. So you're not confused. Yeah. No, it's fine.
No, I did not hear. They said I'm sure.
No, I got it.
Okay, we're ready. Sorry.
Good, all right. Hello, everyone. Good afternoon. I know that we had a very late return last night, so I'm glad that you are here. At this point, I would like to introduce you to our chair for paper session 5, Community Resilience and Aging. So please join me in welcoming Jonathan Inda from the University of Illinois, Chicago.
All right, thank you so much. So my name is Jonathan Inda. I'm a professor and director of Latin American Studies, Latin American Latino Studies here at UIC. And today it's my pleasure to chair this panel on community resilience and aging. So there will be 4 presentations, and we'll get started with the first one. So the first presentation is by Jennifer Salinas, Associate Professor, Center of Emphasis in Cancer, Texas Tech University de El Paso. And the title of the presentation is Pasos para Prevenir, a Lifestyle Intervention to Improve Physical Activity.
Good morning, everyone. I am one of the original emerging scholars. I use the Hispanic EPIs data and the MHAS data for my dissertation. I've written papers, and today I'm going to present to you some of my own work. So I've evolved. I'm an evolving scholar now. So I really appreciate the invitation to be here and talk to you about my program. And congratulations to Flavia for running a great show these last couple of days. I've really enjoyed all the presentations, particularly the students' presentations. I felt like they were really impressive and much smarter than I was when I was at their level. Okay, so I'm going to change it up a little bit because I'm going to actually talk about an intervention that we're running out of El Paso, which is on the US-Mexico border. So I'll provide a little bit of statistic background for you on Texas, on the border region, talk a bit about physical activity. My program is a cancer prevention program, but obviously we do healthy eating, active living. So physical activity, as we know, is very beneficial to cognitive health. So I'll talk a bit about my program and give you some kind of preliminary results from what we found so far, and hopefully link it back to the topic, which is cognitive decline and cognitive functioning. Okay. So the Texas-Mexico border is the kind of 60 miles from the border into the state of Texas, and there's about 3 million people residing in this region, predominantly Mexican-American, although there are other ethnic groups, particularly in El Paso, that are growing in terms of population. Relative to Texas, there's about 29 million people living in Texas, of which about 39% are Hispanic, Latino, or primarily Mexican origin, and about 27% of Latinos that live in Texas live in this border region. So that's a pretty substantial representation when you think about Latino health in the state. Okay. So cognitive impairment, so we've been talking about it a lot the last day or so. And this graph represents or is taken from a paper that uses NHIS data. And these are essentially birth cohorts, right? So what we see here is that over time, actually, cognitive impairment has been declining for birth cohorts. Pretty much starts in 2012, but we see kind of a leveling off with birth cohorts that were born in the 1930s. So people are about 80 right now. Okay, but what you can see here on this graph is that although there has been a decline, there has not been equal decline for all race ethnic groups. And the population that has benefited the most, of course, are non-Hispanic whites, and the populations that still have a disparate representation or disparate incidence or prevalence of cognitive decline or non-Hispanic or non-white groups, excuse me. So in terms of cognitive decline in the state of Texas and the border region, this data comes from the BRFSS. So it is self-report, so there are certainly some downfalls with that, but what we see here is that there is a slightly greater prevalence of cognitive impairment on the border region. About 15% reporting cognitive decline in the last year, relative to about 11.6% Texas overall. And what we can see is that there's a slightly lower report of cognitive decline among Texas residing Hispanic Latinos overall, right? So there's about a 3% difference for Latinos that live on the border compared to living in other parts of Texas. Okay, so I've studied for the time that I've been on the border, which is about 14 years, social determinants of health that drive cognitive function and other health outcomes. And, we've identified, and of course, there's been numerous papers written elsewhere about, social determinants of health, such as access to resources, educational access, built environment, all these things, have also been associated with cognitive decline and cognitive functioning. But I'm going to talk to you about physical activity, not necessarily as a risk factor today, but as a potential place where we can intervene to improve the quality of life of older Mexican Americans and older adults that live on the border. Okay, so there is a ton of literature about physical activity benefiting health, benefiting numerous health outcomes, and of course, cognitive health. So there is a substantial literature that suggests that regular physical activity reduces cognitive decline, improves cognitive function, and benefits your mental well-being overall. Okay, and so again, here are the statistics from the BRFSS, again, self-reports. And we see generally that there's not a lot of difference in terms of engagement. However, border residing adults tend to be the least physically active, and actually non-border residing Hispanic Latinos that live in Texas are the most physical active, but about 30% of adults in the state of Texas, regardless of where you live, are physically inactive. Okay, so my program is called Pasos para Prevenir Cancer. It is a cancer prevention program funded by the Cancer Prevention and Research Institute of Texas. It is a primary prevention program, so we are targeting health behaviors rather than screening or other kind of preventive services. And the reason why we applied for this grant and CPRIT has funded it is because cancer is the leading cause of mortality in El Paso County, where I live, and is the leading cause of mortality in many of the counties on the US-Mexico border. Okay, so my program is multi-level, but today I'm going to talk to you just about the individual level where we provide education, outreach, and navigation. So our education program is based on evidence-based programs. Most of the programs that are out there focus really on diabetes prevention, cardiovascular disease prevention. So we had to do a lot of work in finding the commonalities between the programs, making sure that all the material that we used was available and tested in bilingual populations, so English and or Spanish, English or Spanish, but we did not use any material that was not available, fully available in Spanish. So we narrowed it down to 5 sessions. Generally, sessions go from 12 to 15, but since we're implementing the education, the situation's a bit different because we have to implement to as many people as we can. And people, if you're not paying them to go to the session, generally, kind of drop out after a few sessions. So we have 5 sessions. We provide a menu to our community partners. So we deliver our education in school districts, targeting adults and employees, senior centers, rec centers, the Y. We've been probably, some employers have invited us. So anyone and everyone who is interested in our program, we deliver our program. So they're able to choose from menu, so they can take all 5 sessions, or if they only want 1 or 2 sessions, we kind of tailor and accommodate whatever the needs of the organization are. And so again, our focus is on healthy eating, active living, obesity prevention, and we had to add, because there's no evidence base about cancer prevention. So that was something new that we had to add to our offerings. We provide modeling, so we do cooking demonstrations, we do physical activity demonstrations, and we also have a pretty big social media presence in El Paso, and we provide the modeling through social media as well. And finally, we do navigation. So we link our participants who take our class in person, or we've done online, of course, because of COVID. And so we direct people to free services through our Parks and Recs programs, or low-cost resources in the Y or other programs that are out there. And we also provide recipes for healthy recipes for our participants. Okay, so I'm just going to provide you a little bit of our, because I have 5 minutes now. I'm going to provide you with a little bit of results from our evaluation study. So we evaluated our program in terms of, so we recruited people from our education to participate in our evaluation study. We collected data at baseline, 6 months and 12 months. We have complete data on 209 people. So relative to demography, maybe not a great sample, but in terms of a study like this, not bad. And so what I'm going to present to you is some findings, initial findings on our physical activity outcomes. Okay. So here are some just some basic statistics about our sample. They were predominantly female. We had a pretty even split in terms of age, but about 40% were between the ages of 40 and 59. Good split between US born and Mexico born. And about 76% of our sample had a high school education or more, which is a little bit higher than we might see in other studies, but in line with what we see in El Paso. And also, interestingly, we had a pretty good split between English, Spanish speakers, and bilingual. El Paso is highly bilingual. About 70% of our population speak fluently both English and Spanish. Okay, so just a couple of take-homes from these two graphs. This is average, what we call MET minutes per week. So on the left is moderate, on the right is vigorous. And this is broken down by the places that they engage in the physical activity. So work, transportation, home, or leisure. And so what we found here are two things. First of all, people who engage in moderate activity in El Paso largely do that at home at work. And people who engage in vigorous physical activity largely engage in that through transportation. So a lot of interventions are focused on increasing moderate and vigorous physical activity, but it's important to kind of keep in mind where people are engaging in physical activity in order to effectively deliver an intervention. The other thing that we found was that out of all the types of physical activity, where we had the biggest impact in terms of increasing physical activity engagement and sustaining it was home-based physical activity. Okay, so these tables or these graphs represent changes in physical activity. So we estimated, or we calculated basically meeting the PA guidelines, which is 150 minutes per week at baseline, 6 month and 12 months. And essentially we found that of all the age groups, the 60 plus were the least physically active at baseline, however, were the most responsive to our intervention. And that's kind of the line bars right here. So you're a little short bar at baseline, but they actually increased and sustained their physical activity to the level of younger participants. Other significant findings that we have found so far was that other groups that were responsive were those born in Mexico, where they were the least physically active at baseline, but increased and sustained their physical activity at 6 month and 12 month. Spanish speakers were most responsive, as were our participants who had less than a high school education. So they, in all these cases, not only did they improve at 6 months, but they sustained their engagement at 12 months, which is pretty substantial because, you know, the literature kind of suggests that at 6 months, they kind of start dropping down. And then by 12 months, you know, they're not as physically engaged as they once were. Okay. So just in summary, you know, there is a disparity at the Texas border in terms of cognitive impairment, cognitive decline. And many social determinants of health are responsible for these disparities, right, in terms of access and opportunity. However, physical activity could potentially be one strategy in terms of promoting a healthy lifestyle that might be able to counteract those social determinants of health, because there's some social determinants of health that we can do something about quickly and some that take a lot of time. So physical activity is something that's readily available that, you know, we can act on and improve the quality of life of older adults who live on in our area. So my program, Pasos para Prevenir Cancer, is just an example of one program that could be effective, but certainly there are other strategies out there to promote physical activity. So with that, thank you. And I really appreciate the opportunity to come here and speak to you about my program.
So we'll have time for questions after the discussant. So our next presenter is Maria Cruz Rivera Hernandez from the Department of Health Services Policy and Practice and Center for Gerontology and Healthcare Research at Brown University. The title of her presentation is Medicare Beneficiaries with Alzheimer's Disease and Related Dimensions in Puerto Rico are Migrating to the U.S. mainland.
The arrow like that to move back and forth. Okay. Oh, you would like to? Sorry. Oh, it's fine. Oh, give me 1 second. Let me just minimize that. You should, it says there should be notes here on this slide. When you're on that slide, let me just make sure I'm sharing the screen here. Okay, so you should still be able to use the arrows. If not, you can just click there. All right. Thank you.
Good morning, I'm Maria Cruz Rivera Hernandez. I'm an assistant professor at the School of Public Health and I'm associated with the Department of Health Services Policy and Practice and the Center for Gerontology and Healthcare Research. Thank you so much for having me here. So I will be talking about Medicare beneficiaries in Puerto Rico that are migrating to the US with and without Alzheimer's disease and related dementias, or ADRD as I will be just putting it for short. All right, so this is the agenda for my presentation. So the prior literature regarding to migration among Hispanic populations had largely focused on Hispanic younger adults that tend to be healthier than the US counterparts. But we know from other literature and census data that Hispanic older adults, those from Puerto Rico, might be moving to the US. They have not been necessarily formal studies that have been done tracking migration among older adults from Puerto Rico. But we know that there are certain environmental socioeconomic conditions that might be encourage older adults from Puerto Rico to migrate to the US. There have been death and other socioeconomic crises on the island, as well as events like Hurricane Maria that happened in 2017 that destroyed the infrastructure in Puerto Rico that might have caused older adults to migrate. In a recent study that was published in JAMA Health Forum from my team, we were very interested in looking at the impact of Maria among vulnerable populations, because it would give us an idea about whether vulnerable populations that have healthcare needs migrate. So we track migration among people with kidney failure that need treatment to continue, with care, dialysis treatment. So one might think that, people with kidney failure may not be as likely to migrate. But we have seen that, in fact, people from Puerto Rico that have received treatment in Puerto Rico actually moved to the US to receive treatment in the US. And before Maria, we saw that there was about 8% of those with kidney failure migrating to the US. And after Maria, this rate doubled right after the hurricane. So in terms of describing the island, we know that Puerto Rico has a population that tend to be older than the US. For instance, if we are thinking about percentage for older adults that are 65 and, sorry, something pop up here, and over, there are about 11% in the US of older adults that are 65 and over, compared to 20% of those in Puerto Rico. There are a high proportion of older adults with chronic conditions like diabetes, heart disease, hypertension, as well as cognitive impairment. However, the information about ADRD is not very clear, and this is due to data limitations. So in a recent article published by colleagues and friends recently in the Journal of Gerontology and Social Science, they were describing the issues related to older adults in Puerto Rico. And one of the key things that they were describing was the information that we have to track health and healthcare and outcomes for older adults in Puerto Rico. And this is like all the data available to do this kind of work in Puerto Rico, which is, if we see, limited compared to what we have in the US. So there is population-based data and some survey data that include the census data, the Puerto Rico Community Survey, the VRFSS. There are two databases that track ADRD, and one of these is like reported from physicians and or family members. So there might be some undercounting in terms of like the ADRD prevalence and or incidence in Puerto Rico. And there are some other databases like the HRS and the Boston Puerto Rican Health Study that might have some information for Puerto Ricans that have moved to the US, but they might be limited in terms of sample size and or geography. So the framework for the study is based on information regarding the migration literature, like the Hispanic paradox, as well as the NIA and Health Disparities Research Framework. If we think about the Hispanic paradox, as I mentioned, usually we think about the Hispanic populations that are migrating to the US that tend to be healthier than the US counterparts. And some of the explanations that have been used to describe this phenomenon is the salmon bias hypothesis and the healthy migrant hypothesis, which they posit like that Hispanics that move to the US might be healthier because they have to be able to move and go through the process of navigating different systems to get here to the US. But once these populations are sicker, they might return home to get access to healthcare services and social support to get the care that is needed. However, if we think about Puerto Rican adults, they might not necessarily have the issue of navigating insurance systems because older adults in Puerto Rico qualify for some of the federal programs like Medicare and Medicaid, although access to care and the benefits that they might receive may not be the same as the ones as people here in the US. And I'm happy to answer some of those questions later if any of you have some of that in terms of like the benefits and how that is structured in Puerto Rico. So therefore, the objective of this work which is preliminary work that was done to be submitted with a grant submission. So there are some limitations, and I'm happy to answer to that as well. Is to characterize rates among Puerto Rican Medicare beneficiaries, migration rates among Puerto Rican Medicare beneficiaries, and also to characterize and provide some information about migration rates for people with and without ADRD. So in terms of the data sources I'm using, as I mentioned, there have been some constraints in terms of the data that we have to track healthcare utilization, access to care for all of those in Puerto Rico, and migration also, is an issue. In terms of tracking migration, Pulse Maria, a lot of scientists and researchers use alternative sources of data like GPS data, social media, and different sources just to track where there was a change in migration. So I have used Medicare data to assess different issues related to Hispanic populations in the Medicare program, disparities in quality of care, because I noticed that a lot of the prior literature have excluded Hispanics when looking at disparities. Often they just use the disparities between Black and white populations. And also when looking at Hispanic, whoever was doing this kind of research, they often excluded people from Puerto Rico. So to track migration and ADRD, so I use for this study, I use the Master Beneficiary Summary File, which is an enrollment file for Medicare beneficiaries, and I have some socio-demographic information for all beneficiaries, including those in Puerto Rico. And I use different assessments, from hospital assessments to home health assessments, nursing home assessments, and rehab assessments for beneficiaries, which all of those are complete for Puerto Rican populations as well. So in order to track migration, I use the Master Beneficiary File, which includes information of the area of residence of the beneficiary. And to track people and flag people with ADRD diagnosis, we use the assessments that I mentioned. And I look for ICD-9 and ICD-10 codes, which are included here, which are the codes that Medicare uses to track ADRD among the fee-for-service population. The differences with some of the population for Puerto Rico is a lot of them are enrolled in the Medicare Advantage program. So when tracking ADRD in the master file, the denominator file that I mentioned, often this is not complete for people of Puerto Rico. That is why I have to rely on the different assessments to create a variable that was comparable among, both fee-for-service and on MA populations. And then I will present in some descriptive characteristics from the enrollment file as well. So the primary objective is to track migration, and I will be doing that from looking at who was in Puerto Rico in a given year, let's say 2016, and then move to US states in 2018, so each year. And then for ADRD, we're looking at ADRD flag within the year before migration. So some of the characteristics presented here are stratified by migrant and non-migrant populations. And we can see that people that move to the US are slightly younger. They are more likely to be female. They are less likely to classify themselves as Hispanic, although the majority of people in Puerto Rico classify themselves as Hispanic, as one would expect. They are less likely to be enrolled in a Medicare Advantage program. And so 50% of those who migrated are enrolled in a Medicare Advantage program for the entire year, compared to 72% of those who did not migrate. And this might make sense because if you move to the US and if you have Medicare Advantage, then your care might be more restricted based on provider networks and where you can receive care, whether you can receive care in a US state. And they're also more likely to have an ADRD diagnosis. These are the numbers for people that moved from Puerto Rico to the US. And it's very similar to the graph, the trends that I showed before for people with kidney failure. You see that before Maria, there were about, on average, 10,000 or so beneficiaries that moved to the US compared to about 26,000 or so that moved right after Maria. And these are the rates for people that have migrated to the US with and without an ADRD diagnosis. And the first thing that I want to point out is that people with ADRD are more likely to move to the US compared to those without ADRD. It's not a huge difference, but overall the models accounted for repeated measures show that about 1% of those with the ADRD are more likely to migrate to the US compared to those without ADRD. So, summary, our results show that older adults are migrating to the US, including those with an ADRD diagnosis. And it also appears that Maria have impacted migration among people with different needs, including those with ADRD. Migration rates among older adults and people with vulnerable conditions might be related to environmental and social-cultural factors, as I mentioned at the beginning of the presentation, since Puerto Rico have high poverty rates and a death and a strained healthcare system. If we compare rates of poverty in Puerto Rico to US states, poverty rates in Puerto Rico are about 40% compared to other states in the US that might be similar in terms of characteristics, like Mississippi, which is like 20% in terms of poverty rate. In addition, the death crisis of Puerto Rico has caused that there are limited resources for health care, the healthcare system, as well as social programs. And yet Puerto Rico continues to experience inequalities in terms of healthcare funding from the federal government. Medicare and Medicaid receive lower payment rates compared to US states. And recently, on April 2022, the Supreme Court ruled that the Congress can continue to exclude Puerto Rico from receiving supplemental security income, even though this is a Section 8 program that could benefit a lot of beneficiaries to receive additional resources for healthcare needs. And finally, we know that there are issues in terms of chronic care and disparities in terms of different conditions for people in Puerto Rico compared to the US. And we have found that compared to Medicare Advantage beneficiaries in the US, people in Puerto Rico are more likely to report worse control of certain medications, including those that might require drug benefits and treatment, which might be related to the benefit generosity in terms of the Part D drug-related program, like Part D program from the Medicare federal program in Puerto Rico. So the lack of funding for Medicare and Medicaid has resulted in physician shortages, poorly coordinated care, and long-term care and long-term wait times for people in Puerto Rico. And physicians in Puerto Rico have described this as humanitarian crisis. So the federal government should consider changing the programs to ensure that people in Puerto Rico don't have to leave their homes and come to the US to seek care and long-term services and support. I'm just going to make sure that I have anything to disclose and that I'm funded by the NIA. And thank you, and I'm happy to answer any questions later. Thank you.
So our next presenters are Noreen Segru from the Latino Policy Forum and Marina Del Rios from Illinois Unidos and the University of Iowa. The title of the presentation is Living in a Post-Pandemic World, Recovery and Long COVID.
Good morning, everyone, and thank you for the invitation. So I guess a couple of disclosures as I start. One is I am a co-investigator on the Recover study, which is this large national initiative to try to understand long COVID in the US. I'm also an emergency medicine physician, so a lot of what I'm going to share will be probably littered with personal experiences and stories of patients. And then I'm also a former chair of the Health and Policy Committee in Illinois Unidos. I'm here with Noreen Segru from the Latino Policy Forum, and we've been working together on just trying to call out the injury that COVID has caused in the Latino community for the last couple of years. So this will hopefully give you a little bit of a sense of where we are now. So one point of clarification, we are not post-pandemic yet. I think it's really important to remind ourselves this. So this is just from 2 days ago in the New York Times. And as you see, our daily average of cases is higher than even in March, April, May of 2020, which is when we started decrying that this was a crisis worldwide. Now, the truth is that we are seeing less deaths and hospitalizations, and that in part is due to, thank you, to vaccines and advances in science. But I think that it's really important that we recognize that we are not entirely yet out of the woods, right? And that we're still trying to understand what the long-term impact of this pandemic is going to have in our communities. And then, of course, although, in the beginning, we're all saying, well, everyone has the same risk of COVID, and this is why we all have to protect ourselves and so on and so forth. The truth is that there was a significant disproportionate effect across populations in the United States. And in the case of Hispanic or Latinos, Black and American Indians, we had twice up to 3 times the rates of hospitalizations compared to non-Hispanic white population, and also the death rate was close to twice as high. And this has persisted throughout the pandemic. There's been some ebbs and flows depending on who has been most affected in terms of cases. But again, higher rates of hospitalizations, higher rates of deaths, higher rates of cases. And what that's resulted in is a significant drop in life expectancy. Again, overall in the population, we've seen a drop, but the sharp decline in the Latino population is especially concerning, considering that, again, we just talked recently about the healthy migrant paradox and the fact that, overall the Latino population is healthier because you have to be healthier in order to be able to endure migrating and so on. And so this advantage, to say it right, that Latinos had over other populations is disappearing entirely. And that's, of course, really concerning. And what does that mean in terms of the labor force? And what does that mean in terms of providers for our families, for our elderly population? That still remains to be seen. But we're already seeing some really disturbing consequences of that reduction in life expectancy. So those are the very direct effects of COVID, right? And those are the direct effects that I've had to deal with in the emergency department and caring with very sick patients, sicker than I've ever seen in my over 10 years of a career. And also then dealing with what the consequences are for the families that are now left without a parent, without a child, without a grandparent. But there's also been some indirect effects from the COVID pandemic that we also need to talk about. And so I'm actually not a COVID researcher. I became one out of necessity because I was disturbed by what I was seeing in the emergency department. My research is actually in out-of-hospital cardiac arrest, and I've been involved with initiatives to try to improve the quality of care of patients that have a cardiac arrest. And so a lot of the work that I've done has been improving the system of care, engaging with communities, readying people so that they recognize what a cardiac arrest, how to do bystander CPR, talking to dispatchers, and primarily in Chicago in the Office of Emergency Management and Communications, teaching them about how to communicate with people when they call 911 so that they know what to do in the case of an emergency, talking to hospitals to improve the care of the hospitalized population. And what that's resulted in is that we have seen over time an improvement in the way that we've cared for people, but that improvement has, one, been unequal, and two, with COVID, what we saw is that a population that used to have lower incidence rates of cardiac arrest now all of a sudden have seen a dramatic increase. And so I don't know if I can show a pointer here. Yeah, here we go. So if you see here in 2019, so Latinos in, and this is in Chicago where I did my research, had about a 13.5% of cases of cardiac arrest in the city of Chicago were Latinos, which is lower than the proportion of the population, right? Which is around, I think it's 25 or 26%. Noreen, is that right? 30.1. Okay. So, lower in proportion, but what we've seen is that over the course of, and this is just 2020, and from what I'm seeing from 2021, and the pattern for 2022 is very similar. That this number of cardiac arrests has gone up to 17.3%. So, I mean, that's a pretty significant, that's like a 40% increase, right, in the span of just 1 year. And this is just considering a cardiac arrest is usually kind of this end outcome of prolonged cardiovascular disease. And most cardiac arrests have some undiagnosed subclinical cardiac disease, right? And so what this means is that over the course of the pandemic, that population has seen an increase in cardiovascular risk. So these, again, indirect results of COVID, right? This is not directly COVID causing cardiovascular illness, but the fact that we've dropped the ball on the care of other chronic conditions. Another indirect effect of this pandemic has been mental health, right? And who is affected by more rates of anxiety or more rates of depression varies widely across communities. And what we've seen is in the case of the United States, Hispanics, about a third, are now reporting anxiety or depression in the coronavirus pandemic, which is higher than the rates that we've seen in the past. And of course, when you combine the fact with the fact that a lot of our population is low income, that they have a lot of comorbid illnesses, and with our aging population, all of that combined, right, it's just a recipe for disaster. I couldn't find a good study from the US to understand the impact of mental health, not just overall, but also how it really varies depending on what your family situation has been. But this is a really good study that came out of Europe. This is a survey of retired adults. And what you see here is who reported an adverse psychological state that basically resulted from being in the midst of this pandemic. And so while there's a good portion of the population that, at least in Europe, right, they didn't report that, there was a significant number of people that are now reporting being nervous, sad, with trouble sleeping. And then when you compound that with both, okay, so of those that are saying that they're more either anxious, depressed, or have trouble sleeping since the pandemic, how that relates to how COVID has impacted them, the great majority of them are due to COVID
having arrived in their household. So whether somebody tested positive or was hospitalized or died. So when you think about the fact that in Latinos in the US, we've seen a disproportionate number of cases, a disproportionate number of hospitalizations, a disproportionate number of deaths. What that means is that we're going to see a mental health crisis like we haven't seen before, because more people are anxious, depressed, and having difficulty sleeping, not because they themselves had COVID, because it hit their home. So then we talked about the very acute effects of COVID, that's hospitalizations. We talked about the indirect effects of COVID. Now we have to also deal with the long-term consequences of the pandemic itself and what that means for this a huge number of people that have been affected by COVID. And so, one more piece. So the other indirect effect was also been preventive care delay, right? So we talked about cardiovascular disease. There's also been an inordinate amount of people that have had to postpone their cancer care. And although in the white population, that's been very much a decision of the patients themselves, in the Hispanic population and the Black population and Native Americans, a lot of them has been at the request of their providers. So canceled appointments, delayed care in that way. And what that means for all of that is that we're seeing higher lengths of stay in the hospitalization for diseases that in the past would have been, just a couple of days hospital stay. And we're seeing higher mortality for non-COVID illnesses, higher mortality for heart attacks, for cancer, and so on. And then there's the long-term effects of COVID itself, which we know the SARS-CoV-2 virus can affect multiple organs. It can affect the brain, the lungs, the circulatory system, the immune system. We still don't fully understand what the post-acute sequelae of COVID are, but we have a sense based on just surveys. This is a survey that we did here in Chicago. Fatigue, trouble concentrating, body aches. So this might explain why there's people that are not returning to work or having to cut back on their hours, right? And just to talk about the major impact of this disease in our population, 1 in 13 adults in the United States report long COVID symptoms. I'm not talking about, just the people that had COVID, 1 in 13 US adults. And in Latinos, the proportion of Latinos that currently have long COVID is 9%. So 1 in every 10 people have long COVID. And what we're seeing is that long COVID has affected largely the more younger adults than older adults. So these are the people that are breadwinners in our families, right? That are working, that are the productive members of society. Nearly 3 times as many adults ages 50 to 59 had long COVID compared to elderly. And women more likely than men, which again, women are the backbone of Latino families. So with that, I'm going to hand this over to Noreen so she can talk to you about more of the socioeconomic consequences of that.
Thanks, Marina. Thank you, Flavia, for the invitation. Rather than go through a bunch of slides and sort of tell this audience what I think a lot of you know, I want to talk a little bit about how to use health data and how we think the health data should be used to structure policy, and we're doing it with the Latino community. And just a sort of shameless plug, on October 19th, the Latino Policy Forum and Brookings is putting out a long-term COVID report. Marina and I will be doing the national webinar, so tune in. We're not looking at long COVID as a medical issue, but we are actually looking at long COVID as a socioeconomic crisis in the Latino community. So when we think about what's going on with the Latino community, Marina talked a lot, and all of you know there's 5 minutes, cool. All of you know the disproportionate impact. But we have to remember that that impact is far greater than even the numbers say. Even at the height of testing, when there were testing centers on every corner, Latinos were being tested at the lowest rates of any racial or ethnic group. That means that the numbers we saw were far lower than what was really happening in the community. What we are suggesting is that when you look at the descriptive data, particularly when it comes to elderly, we have to begin to rethink the socioeconomic programs and the programmatic interventions. The death rates of those 20 to 59 are highest in the Latino population. That means that the entire family and economic structure that Latino elderlies live in, they live in multi-generational houses, they rely on family, they do not have the economic resources to, retire to Arizona and play on the golf course. It's a familial notion of retirement support. The breadwinners are dying. The 20 to 59-year-olds who are dying are males. It also means that when Latinas, who are the drivers of workforce growth and are projected to be the drivers at least through 2030, when they go back to work, they are not relying on childcare that they pay for. First of all, they can't afford it because Latinas make the least amount of average earned income per week of any racial or ethnic group. They're relying on seniors, grandparents in the home. These are grandparents who are grieving the loss of their children, sometimes their grandchildren. They're being called upon to restructure and help restructure a family that's in both economic and mental health crises, and we have no mental health workers. Kaiser Foundation is estimating more than 30% of Latinos can't even access a mental health worker. And that's people with diagnosed mental illness. And so the question becomes, how do we think about the policies? And one of the things, and this is a war story, Marina and I have spent endless hours fighting with city and state officials. No, you just don't give out money based on population proportion. It is imperative that when we put out our programs and policies and we do our evaluations, that we apply the lens of Latino equity. And one of the biggest arguments is we need to look at the impact at the micro level. And we need to understand how fundamental social structures that give rise to a term I really hate, Latino resilience. It sort of lets people who support inequity off the hook because you say, oh, people are, they don't need help, they're resilient. But if we don't move away from the way we evaluate programs, if we do not insist that the Latino lens be central to all evaluation, the Latino seniors are going to lose the most because they're among the most vulnerable group, because although Latinos are no longer an immigrant population, there's more native born than immigrant, it is elder Latinos who in fact are immigrants. And it is elder Latinos that have, and I've got 1 minute. Okay. So basically the idea is that as we think about long COVID, the medical stuff is important, the cognitive impairment stuff is important, but the way we structure policies and evaluate policies, particularly among Latino seniors, has to take into account ways that historically we haven't looked at policy. And we haven't looked at it with a notion that there's been a fundamental change to the very structures that have given support and an ability for people to seek healthcare, et cetera. That's gone. And you can hear more about this on October 19th. Okay, she put up her sign.
So this is the final presentation. The presenter would be Sunshine Broke, Associate Professor and Interim Director of Research at Kent School of Social Work at the University of Louisville. And the project also includes Kyriakos Markides, Annie and John, Yitzinger Professor of Aging and Director of the Division of Social Medical Sciences at the University of Texas Medical Branch, and Jacqueline Angel Wilbur J. Cohn, Professor of Health and Social Policy and Professor of Sociology at the University of Texas at Austin. And the title of the presentation is The Caregiver Stress Process Model, Mexican-American Caregiver Turnover and Depressive.
Thanks so much for having me today. So in the program, it said caregiver turnover, but we didn't have enough time for that today. But we're going to be having a GSA symposium on dementia care in the US and Mexico with Phil and Mariana and Jackie. So if you're at GSA, please come to that and we'll talk about caregiver turnover there. So thanks. So today I'm focusing on looking at changes. So I did a similar presentation, I think like 7 years ago at this conference, looking at one wave of data. And so now that we have two waves of data, this is like a remix, right? Looking at longitudinal change in caregiver mental health over time with the Hispanic EPI's caregiver supplement. Yeah, so, oh, I thought I did that. No worries. Okay, this is great. So just for a little background on caregiving in the US, so there's over 40 million people in the US who are providing unpaid care to an older adult, and the economic contribution of this care is about $470 billion. And we know that also that unpaid and family-based care is more prevalent for Mexican-American families in the US compared to other groups. And as we talked about yesterday in a couple of the presentations, this is both due to cultural orientations such as, familism and the emphasis of family support and reciprocity, and also structural barriers that we mentioned as well, and inequities in access to paid formal care supports. So in terms of research on Latino caregivers, there's evidence that the time spent on caregiving, which is a major stressor within the caregiving domain, and the financial costs of caring are more impactful and challenging for Latino or Latinx caregivers. But in spite of all these challenges, we also find a lot of qualitative and quantitative research showing that Mexican-American caregivers also report very positive attitudes or orientations towards caregiving. So things like, feeling reciprocity, love, and duty when providing a care to an older family member. But there's very limited longitudinal research on caregiver mental health, especially for Mexican-American caregivers, using population-based data. So a lot of the early caregiving research focused on Latinx caregivers really focused on clinical studies. And so this population-based data is really looking at caregivers out in the community, seeing their change in health and seeing what's going on there. So hopefully by understanding, the precursors to caregiver mental health, we can really have an impact on intervention targets and prevention methods, right, to improve caregiver well-being. So today, the results here are really informed by the socio-cultural caregiving stress model, which was really explicated and explained by Maria Aranda and colleagues. And it draws from just general caregiver and general stress and coping models. So first is the role of background and context, which we know can influence the stressors that are experienced, as well as caregivers' mental health. We also know that these background and context factors impact resources, such as like support within the family and outside of the family as well. That can also be beneficial to caregiver mental health. Another important process here is the looking at appraisals. So stressors are really impactful on mental health if caregivers deem the stressor as stressful, right? So that's a really important mechanism I think that goes underlooked there. So we're looking at, how the caregivers appraise the caregiver situation as well. So these are this model really informed what kind of variables that were available that we could find also in the Hispanic EPI's caregiver supplement that we could use in our results today. I don't present on, there's mediation, there's moderation we could do here, but I don't present that today, just the direct effects of all these different factors. So the research question is, which caregiver background factors, stressors, appraisals, and resources are related to, we're looking at in particular, which is also a really big emphasis in the stress literature, is looking at multiple outcomes, right? So looking at both positive and negative outcomes that could be related to the stress experience. So here we're looking at changes in depressive symptoms, perceived social stress, and also life satisfaction over 5 years in the Hispanic EPI's caregiver supplement. So the Hispanic EPI's, as many of us know, is a longitudinal data source of Mexican-American adults 65 years and older. In 2010, 2011, older adults participating in the Hispanic EPI's were asked for the contact information of the person they are closest to and rely the most on for help. And 925 of these, what are called informants, were interviewed, the majority of which we determined were caregivers and providing care to the older adult. In 2016, there was a follow-up. And so older adults, again, were asked the same question. And so this is where that turnover piece that I'm going to be presenting at GSA comes in, because there was some turnover in terms of the caregivers. Obviously, some older adults died over the 5 years. And so looking at those changes is what we're going to be doing in that future presentation. But out of these, so 460 caregivers were interviewed again, and 218 were the same caregivers from baseline. So that's who's included in this current study. Actually, 191 who had complete information on all the study variables. So this is just a brief, description of the caregiver sample. So just in terms of, I'm going to just highlight a couple of things. In terms of depressive symptoms, there was a mean change of 1.4 on the CESD scale. Perceived stress looked pretty similar. So there was only about, the mean change was actually a negative 0.1. In terms of life satisfaction, about half of the caregivers reported similar life satisfaction at baseline and follow-up. And about a quarter reported either worse like lower life satisfaction, and a quarter reported better life satisfaction at wave 2. In terms of background factors, what's unique, I think, to this caregiver study compared to other population-based caregiver studies is that 69% completed the interview in Spanish, and also the majority, 70%, are adult children of the care recipient, which in many population-based studies, spouses are over included in terms of who the caregiver is. So this is, I think, a unique feature of this sample. In terms of objective stressors, so we're looking at objective stressors, which are changes in the care recipient health or the older adult health over time. So these objective stressors, we're looking at change in NPI or neuropsychiatric symptoms or expressions of dementia. So these are things like wandering, agitation, anxiety, which are really challenging for family caregivers and can be really hard to navigate, especially if there's not really a big campaign to educate caregivers on these types of symptoms, so they can be very challenging. Also, there's about the mean for change in ADLs and IDLs was about 2 over the 5 years. And in terms of caregiver appraisals, we're looking at the family puts too many demands on me as the caregiver. And that's about 23% of caregivers reported that. And then we also wanted to have a positive appraisal, right? Because we know there's positive appraisals of caregiving too. And so we included the caregiver wants to spend more time with the older adults or the care recipient. And about 52% actually wanted to spend more time with their care recipient. In terms of resources, so we looked at perceived social support as one of them from both family and friends. And we also looked at help outside of the family. And this was from neighbors, churches, or senior services. And about 50% reported some help from outside the family. So first, this was the results for changes in depressive symptoms. I only included the things that were significant. So first was NPI. So here, NPI symptoms were marginally significant. So change in NPI, which means an increase in these neuropsychiatric symptoms or expressions of dementia over the 5 years were marginally associated with an increase in depressive symptoms for the family caregiver. In terms of background factors, we only found that Spanish interview was significantly related. So I kind of wanted to break this down in terms of the bivariate to really kind of give you a picture of what this change looks like for caregivers who completed the interview in Spanish. And so here you can see that there was an increase from 3.74 symptoms to close to 6 symptoms between the 2 waves only for the caregivers who completed the interview in Spanish. And for caregivers who completed the interview in English, we see it's about a similar, even though it's higher than for the Spanish interview group, it was high across both waves. Also, we found perceived support was also significantly related to change in depressive symptoms. And these are the predicted scores from the regression equation. And here, so what you can notice here is that so at low levels of perceived social support, so this is like saying, I really can't rely on my family and my friends very often, there's like a higher change in depressive symptoms. So here, you can see that, but at 1, there's a higher, and then it goes down, the more support that's reported. And this was just support at 1 time period. So I wasn't looking at change in support because we didn't have it at both waves. But obviously the caregivers who reported that they have family and friends that they can count on report less of a increase in depressive symptoms. So for perceived social stress, the only thing that we found significantly related was Medicaid receipt. And so we found that caregivers who were on Medicaid showed an increase between the waves, which is a relatively minor one here. This is at the bivariate level just to show what those changes look like. And so you could see a slight increase for caregivers who are recipients of Medicaid versus those who aren't. And this kind of, this definitely makes sense in terms of the research presented yesterday by Mariana, looking at the economic strain related to family caregiving. And so it makes sense that the economic consequences, the perceived stress would be a lot higher for lower income caregivers who have to navigate a lot more challenges. And so that was the only significant result, yes, for perceived social stress, is this group here. And then finally, we looked at life satisfaction here. So this is a little more confusing. So these are the results from multinomial logistic regression. And so we have, the base groups and the comparison groups. So it can get a little funky here. But the base level here is life satisfaction was the same at baseline and follow-up. And here I'm presenting for the category of lower life satisfaction at wave 2 compared to that was the same across. And we found significant differences was first with ADLs. So we found a change in ADLs, so an increase in ADLs over the 5 years was associated with reports of lower life satisfaction, right, at the second wave, which makes sense. And here are just the predicted probabilities from this, looking at the change in ADLs. And so, I guess the important part here is to notice that at less change in ADLs, there are less caregivers who are reporting worse life satisfaction. And those caregivers who are reporting a change in ADLs from 4 and above are more likely to report worse life satisfaction at the follow-up. We also had too many demands was also marginally significant. So having too many demands placed on family members was implicated in life satisfaction for caregivers. And then also we found that our resources were important for life satisfaction. So here again, we found that social support, so similar to the results for depressive symptoms, that social support is also related to life satisfaction. And Also, we find that help outside of the family, so again, this was from churches, social services, neighborhoods, was also significantly related here. And so you can see that there's better life satisfaction from these predicted probabilities from the regressions for caregivers who did receive help, right, from outside of the family. And so I think these results also really kind of highlight some of our qualitative work that we've done. It really supports our other qualitative in-depth interviews we've done with family caregivers, really showing the importance of not just support within the family, which is really a strong emphasis of intervention and prevention methods, but also access to support outside of the family is a huge, huge issue that needs to be addressed, especially as we know family sizes are changing, families are becoming smaller and more demands are placed on a few caregivers. We're going to have outside family support in terms of making these caregiving situations viable, right? And so caregivers can continue being caregivers, can continue having a positive orientation towards it, and also for the health of the older adult as well. So some of the take homes I have from this looking at these changes over time, where a lot of the factors that we did look at were significant in our cross-sectional studies hold over time, so that's also really helpful and good for us. But strategies that address education on dementia, especially those neuropsychiatric symptoms I mentioned, is very key for all sorts of populations, especially health disparity populations. And disability-related supports, caregiver safety, and also screening for dementia and getting proper access to diagnoses for dementia is very, very important. Also, what I talked about briefly too is increasing dementia caregiver supports both within and outside of the family. So really seeing how both family preferences for care. So we found in some of our other work with Hispanic EPIs looking at adult daycare usage, and this has been related to a lot of positive caregiver health outcomes. And adult daycares are really important because the older adult still lives at home, but it does give caregivers reprieve or even just time to work or do other meaningful tasks and some time away from the caregiving responsibilities. So adult day centers are really important, we think, for this group. And could be really important at reducing caregiver stress. And then, of course, improving access and affordability of formal care supports for low-income caregivers. And then also dementia care outreach should focus on the unique support needs of Spanish-speaking Mexican-American caregivers. So thank you so much. That was my presentation today. And this research was funded by the LRP program at NIH. Thank you.
Sorry, everyone, just 1 minute. Maybe we'll just leave that up for the question, just in case anyone on Zoom has something that they wanted to ask.
Okay, so now we have our discussant, Octavio Martinez, Associate Chair of Diversity, Equity, and Inclusion at University of Texas at Austin.
Yeah, thank you, Jonathan. Great panel, great discussion, great presentations. So let's first, I'll give you my insights on Pasos para Prevenir by Dr. Jennifer Salinas. I thought there were some very key things that came from her presentation. One of the things that I think came across is the fact that knowledge and the effectiveness of programs tailored to population along the U.S.-Mexico border definitely are in greater need. And so good to see that has started with her research. And that gap in knowledge is really, I think it tells us about what are the effective strategies for economically diverse populations. As she was looking at working class adults versus our elders, right? So she definitely, I think, highlighted primary prevention program. And also was unique, obviously, because of the pandemic, it was in person, as well as online. So I think that also speaks to some of the creativity now and actually acceptance of new ways of dealing with our populations. I took away also that younger adults of working age are more inclined to improve their activity where? At work, versus older adults who are more likely to improve their activity at home. So teasing apart those, maybe heuristically we would think that, but it's also good to know that we have evidence base to show that that in fact is the case. And also that in fact 60 plus individuals are more responsive versus the younger participants. And are, I think this is the key part, especially at the 6 months to the 12-month level, it's sustainable. Because often, as we know, many interventions start out very robust, but do they maintain? And so her research is showing that in fact, yes, that is possible. So using a tailored intervention approach may be effective in improving physical activity. I think that's a really key takeaway. Our second presenter, Medicare beneficiaries with Alzheimer's disease and related dementias in Puerto Rico are migrating to the U.S. mainland by Maricruz Rivera Hernandez. Another also, I thought, very interesting presentation and paper. One of the takeaways for me was that she really was able to highlight overall, we took a lot of, looked at what's impacting the social determinants of health, really just came out to me. And they're influencing our older adults in Puerto Rico are now moving to the mainland. And really interesting to see and to think about that not only is it the social determinants of health, but also trauma events. And in this case, it was a, one which was caused by Hurricane Maria. So the Hurricane Maria effect of 2017 was really quite significant. And just like the US, the island population is aging as well. And so I think that's an important concept because a lot of folks think of Puerto Ricans when they're coming to the US as being very young. She's indicating, well, in fact, we're putting that on its head, right? So that healthy migrant model needs to be relooked at, especially when it comes to La Isla de Puerto Rico, where in fact, that is really showing a very significant increase in individuals that are older, and especially dealing with dementias and Alzheimer's disease of other types. The other thing that I think came across in her paper that is very significant and important from a policy standpoint is colonialization and the discrimination, which is very much structural in nature when it comes to how Puerto Rico is seen by the US. In fact, there is now from social determinants, structural determinants, there's another term out there for you to be realized in the public health arena, which is the political determinants of health. And in this case, she showed an excellent example of that with SCOTUS, our Supreme Court of Texas of the US, ruling in the US versus Vallejo Madero case, where Congress can continue to exclude Puerto Ricans on the island for supplemental security income. So the colonialization and the way that they view the individuals of Puerto Rico and the population continues, and it has dire consequences. And so there's the other thing that I think she brought about was really the challenge that especially researchers have across the spectrum, which is about having good access to data, right? So it especially is important that we not be seen as monolithic, but in fact, we can disaggregate the data. And that's one of the things she was challenged with, but found a way to still be able to put together, I think, a compelling paper. The other thing that came across to me was, and it's very significant, and it's important when we look at elders and the whole concept of aging in place. And in fact, the political determinants, the social determinants are not allowing that to happen now for the elders of Puerto Rico. You cannot age in place in your own home, in your own community, and they're having to migrate to the United States, to the mainland. Our next paper by Dr. Maria del Rios and Noreen Seguru, Living in a Post-Pandemic World, Recovery and Long COVID. Also very compelling and of course very timely, just like all the other papers are. But I think the first thing that she said we mustn't forget, we are not in a post-pandemic world. Everybody's wanting to go back to normal. Well, there is no normal. All we can do is adapt. That's what human beings have always done, and we need to learn to adapt. So I thought she did a very nice job of bringing that together and breaking it down between direct, indirect, and of course, long-term consequences. From the direct category, not only are we not in a post-pandemic world, but higher rates of cases, hospitalizations, death. I think many of us are very much aware of that. It hit all the airwaves, social media, you name it. Unless you were under a rock, you would have known exactly what's happening to communities of color, and especially Hispanic and Latinos. And also the sharp decline in life expectancy. We've been hearing about that, but it's been always in the aggregate. I think it was really nice that she was able to tease out and disaggregate how it's impacting the Hispanic Latino population. And the implications are widespread. And it would take too long to actually go through what what those impacts are. But I thought she did a pretty nice job of getting us on that track and thinking about what happens when one of our elders does die, let alone anyone else, like an adult in their work in the midst of their working life. Indirect effects, definitely. I know in the medical community we've been not very much aware of this, especially how there's been an impact in now higher mortality due to preventive care being delayed. But I thought it was really significant, especially her data on increased cardiac arrests. As she pointed out, 40% increase just from 2019 to 2020. That is huge. And then think about the impacts that the death has on a family and a community. And then the third increase, and of course, this one I'm very much well as being a psychiatrist, is the mental health crisis that we all were saying is going to be coming, because pre-pandemic, it's not like we had a really robust mental health care system in this country. Pandemic has made it worse, and she definitely is feeling that herself as an ER doctor. And yes, we're headed into a mental health crisis for the entire country, but once again, it's going to be disproportionate and disparate when it comes to communities of color, and especially, unfortunately, for Hispanic and Latinos. Long COVID, yeah, we need a lot of research to continue with post-acute sequelae of SARS-CoV-2. Long COVID is also known as PARS for PAS, in the medical, but the long COVID and the consequences it had are quite significant. And older adults, I thought was interesting, are less likely to have long COVID. And you'd be interested to see why is that the case. I have some ideas, but those are just heuristic versus having good research. But the socioeconomic crisis, I thought that Noreen brought for us to think about is really quite critical as it impacts the Hispanic Latino community. And I do like that that view, that model that they were putting forth of how to think about what we need to do, because what in fact it means, as she was stated, is you need to apply an equity lens to the impact that it's going to have on our communities. And when it comes to the programs and the resources, because the programs and the resources are not keeping up with the dynamics of the way the pandemic has impacted us, let alone how the world is changing. And so that is, I thought, quite significant. And then our last presenter, Sunshine Roti, I thought did a wonderful job with the caregiver stress process model, Mexican American caregiver mental health. I was very excited to see the concentration on the caregiver. We concentrate a great deal on the beneficiaries, or what we call the consumers or the patients, but we also must not forget those that are providing the care. And so that's a very significant point that was brought up. Focus on the caregiver. Once again, though, there is limited longitudinal research. More needs to be done to be able to tease apart that and really drill down on what can we take away from this. But I thought she brought some very good points to bear, along with obviously the work of Dr. Angel and Dr. Marquez, which is that prevention and intervention approaches for addressing depression in Mexican American caregivers is a key area of focus that needs to be looked at. Noting that the greater perceived social support from family and friends, in fact, was associated with better caregiver mental health as it relates to depression and life satisfaction. And I think that is a very key as well. The other thing that comes across to me in their presentation in the paper is culture continues to matter a great deal. And not only culture, but language, right? So I thought that came across in the data. Psychosocial and mental health interventions should be tailored to the unique support needs of Spanish-speaking Mexican-American caregivers. And also, when it comes to the increased dementia caregiver support going forward, that we must, in fact, continue to understand the impact it has, that kind of support needs to decrease caregiver stress to be able to have the best outcomes, not only for them, but for the entire family unit. With that, I'll turn it over to you to think about what you're thinking about and your questions for our panel. I think we have Bill.
It doesn't matter, whatever you feel like you want.
I thought that was a wonderfully generative set of presentation because they come together on a specific issue, which is the impact that these changes are having, the capabilities of social methods to sustain individuals to support their needs. You know, and to me, it brings up a very critical issue that goes back to those of you that are sociologists out there. It's like a structured string kind of model where you've got a system under tremendous pressure, under tremendous stress of various kinds, and they're coming up internally with all kinds of adaptations to confront that, to offset that demand. And arrangements within families, and we all know how that goes in all kinds of different ways, sometimes very pernicious. The bottom line in my mind is that, and I would ask this as a question to you, I mean, what do you believe that the critical disjunctions that are there in the system of care that are supposed to be aligned with these pressures? I mean, are they really misaligned with the kinds of pressures that are taking place in these families? And what can we expect going forward? Because I expect this to continue to get worse, given the fact that half of these families are living on rentals. They're going up and up and up, and the scarcity and pressures that that's creating. The alignments that creates inside the kind of rearranged resources and human resources COVID. What do you see as the impact? I think of the Puerto Rico study because I see people coming from a low resource base to another low resource, and the impact it's having on those families that are receiving those people. And how is that supposed to work out in terms of the way our state systems and federal systems respond to that? Because I think that's what we lack knowledge. And I see two things happening. One is that some states have enough money and they don't do it right. California, okay. Other states don't have enough money or they're not putting out enough money to do it right. And so we have two different kinds of problems. But either way, it's the configuration of alignments that take place between what these dispositions and adjustments are and what in fact systems are actually producing and delivering.
I think what you're
I kindly ask that you either go here or by the microphone so everyone knows. Yes. Sorry to be involved.
I think what you're pointing to is stuff that we've been working on and talking a lot about since actually April 11th, 2020. And that is all COVID did was expose and exacerbate an already broken system. And the misalignments you're talking about were in place and solidified through policy and through resource allocation pre-COVID. All COVID has done is make it worse. And the language of Latino resiliency, the media, and we actually have a piece that came out in JAMA Ethics, the media story of not the Latino community not being as disproportionately impacted as it was, really was damaging. JAMA put out an article that said that there should be resources for mental health to children who lost parents. Latino kids have the highest rate of loss of caregivers. The word Latino or Hispanic did not appear in the article. The misalignment is not just a misalignment of systems, it's a misalignment of how we evaluate and what we accept as policy. We did it pre-COVID and continue to do it. I don't know if that answers.
Good point.
Hi, I'm Bob Wallace from the University of Iowa. I'm the evaluator. Sit at the back. Now's the time to make a quick comment. I just wanted to say, because I was involved in it to a small extent, that the Puerto Rican experience and Hurricane Maria is an acute laboratory, terrible one of some magnitude. And using all the data sets that you've assembled was really more than I've ever seen in terms of what was really a big political to-do, which was that I even got as far as the Congress, which is how many people died. And looking at migration, looking at families, which you can do. Excuse me?
Yeah, raise your hand.
is something that that really hasn't been done, and I think is really important to understand the acute effects of natural disasters of some magnitude.
Yeah, thank you very much for all the comments and encouragement, because so this is an issue that has been brought by NIA that they are very interested in looking at effects of climate change and migration, and we have noticed that, well, we have a huge event that just happened. Let us see how that impacts migration on these different populations. And as others have noticed, we should think about Hispanic populations and people that are healthier and that are able to do jobs and things like that, and not often think about people that are suffering from vulnerable conditions. So this is this type of data that we have access to the center, and I'm very thankful that we have it. And hopefully we can get that grant funded to add additional information that will let us know a little bit more individual information about other social needs and social factors, to be able to, to have a better picture of who's moving, what kind of support they have, and what other different outcomes in here. So thank you very much. I like the encouragement, and I appreciate your words.
Yeah, I had a question for Dr. Roth. I know that you do some work on other caregiving groups, not just specifically Latinos, but on caregivers in the United States in general. And what I was really interested in your study was one of the only predictive factors for increases in depression among Latino caregivers was that Spanish language interview. And so I was wondering how you think that kind of situates when you're thinking about other caregiving groups where you don't have that factor, you don't have this sort of language effect, you wouldn't be calling that. So what do you think that's really telling us about their experience compared to other caregivers?
Yeah, I think there's like a lot to unpack in that one variable, right? So it's Spanish language interview. From our qualitative okay. From our qualitative race research, I kind of have a better idea because we've actually, have interviews, detailed interviews with Spanish-speaking caregivers. The report, like, okay, when I first took on the role, I was happy in it, and it was, I could manage it. But over time, as these stressors mount, our family is more traditional, so I'm responsible for all the caregiving, or I don't have family around to help me. I don't have siblings who are willing to help out, or they're dealing with their own chronic health conditions, and they can't be caregivers. So it's all falling on me. And so also that cultural orientation of the older adult only wanting to hear from family is also another stressor that those caregivers reported within that kind of qualitative information. So I think that Spanish language interview is like a lot to unpack there. It's not just one thing. I think it encompasses a lot of different cultural contexts, a lot of different structural contexts, right? But yeah, so I haven't really thought about the other caregiver groups since we don't really look at language use. Yeah, I know. So I'll have to think about that. So you answered a really good question.
Thank you.
Yeah, thank you. Yeah.
Oh my God, thank you so much for those wonderful, wonderful presentations. I want to keep with the theme of language. And one of the things that Maureen just said just is really resonated with me. We're in an era, especially with this post-George Floyd heightened awareness of racial justice and social justice. And in the context of that conversation, a lot of times Latinos are invisible. And one of the things that is most striking is the invisibility of linguistic minorities. And I say that oddly because in the United States, it's almost, Spanish has become almost the default language. But we're in a language context in which it's very hard for many people to understand how difficult it is to navigate from one language to another. We know this as researchers, but when you there's a real problem in not providing trainings in Spanish for workers, and so the workers are not getting this information. And then the number of bilingual workers being able to provide that that information to. So you had that wonderful, the last slide where you're like, there's special needs of Spanish speaking clients. But you get into this language obstacle, and it's not an easy one to overcome. So I would just wanted to open that as an important conversation to the county, because it's actually a structural macro, and it's also a micro, and things are just not getting through that pipeline because the language barrier is there. So, you guys. Thank you.
I think we're almost out of time. So we're out of time.
Okay, well then we had Elizabeth had a question, so I'll get Elizabeth to come back up. I don't know what she got.
I had given up on that question.
Yeah.
So my question is very straightforward, and it's at the intersection of what you guys presented about all this generation that is dying and the generation that is providing care. So we know policies take so long to be implemented, and you're suggesting there has to be a transformation of the policies that we have. But how is that going to be done? I mean, what do we need to do as researchers to get you to that stage where the policies are in place? And what can we do to emphasize this own paid care that people are providing, and the people that are dying that are not going to provide that care? So I think like this conundrum is kind of challenging. And I don't know that there is one solution, but if you have some thoughts as to what should we do to get to that next level, because all I heard is there is going to be a tsunami of mental issues, there's going to be a tsunami of economic disposition and resources, and I still have my dad that I need to think about. So I just want to know if you have any thoughts. So it's technically a question for the two of you. So. You're like, who's gonna jump?
I think Lincoln, sorry about the conversation, but she was talking about paid family caregiver support and paid leave. I mean, I think that's just really, really an important policy step for caregivers, just because of the financial strain related to caregiving, the occupational, challenges that poses. But how do we get there as researchers? That's a really great question. One I'll think about. I don't have the idea.
I'm happy to speak to that. Just as someone who's learning this. So I'm actually here in Chicago for two different conferences. I'm also at the Women in Medicine Symposium, and my presentation is going to be on physicians and allyship and the importance of getting involved in community organizing. So I think that the piece here is I think we can measure as much as we like and report as much as we like, but at the end, we have to do more than that. And so one thing that I've learned with this pandemic is that change doesn't happen unless you're talking to decision makers and people with money. And we have a very powerful thing, which is data, right? And and so the power of narratives combined with data, I think, is what has led to at least some policy changes over COVID, which they're not all long-term, some of them are, right? So in the state of Illinois, for example, one of the things that we fought for was expanding public aid. And now we have public aid available for people over the age of 45, regardless of documentation status. That's huge, right? I mean, it doesn't fix the problem of a broken healthcare system and the fact that we don't have enough mental health services and the emergency departments are overcrowded and et cetera. But it does reduce the financial burden for families that may choose not to seek healthcare because it's going to break the bank. But we have to continue doing that and trying to find spaces to push policy so that it's not just reporting, woe is us, Latinos, and all the medical problems and healthcare problems and the financial situation that we're in. But no, there's dollars. This is a very rich country. We can fix this. We just have chosen not to.
I'm just going to add to that. I spent 22 years as a faculty member in Champaign, and now I'm doing applied research. And the reality is that academics need to learn to not talk the way the papers were presented at this conference. They're excellent work. They're extremely interesting. They're illuminating. 3 points, can't get more than that. And it's sometimes you don't even need to talk about your own research, and I even find that in the applied world. I'll come up with the analysis. I don't get to do it, but I give it to the person who can pick up the phone and call the deputy governor and get it. And that's really hard to do. But that's sort of the reality.
So thank you everyone, and thanks our panelists for a wonderful panel.
So one picture, and then we move to the next session. Thank you so much. Thank you so much. Jennifer?
Yeah, there you go. We should do.
Just one for someone who has a best
All right, everyone. It was an exciting session, that's for sure. I would like to invite you.
Get ready for it. Really good seeing you, okay?
At this point, I would like your attention. I know that it's very exciting and to meet and to be here. I love seeing the energy in the room, especially after some coffee. But I'd like to invite you to our keynote, our second keynote session. So at this point, I would like to welcome William Vega from the Florida International University, who is going to introduce our speaker.
Okay. Well, let's keep that excitement going. Okay, I think that we've hit on a verb here, a nerve that's reacting. And with this acupuncture, we're going to bring up our next speaker. Octavio was just up here, so it's a little difficult to say that I'm giving you anything new, there. But I just want to tell you that I think he's going to be hitting on a topic that is completely coordinated with what we just heard from the standpoint of understanding structural related issues. He's the executive director. Well, he's a professor at the University of Texas, but he's executive director of the Hogg Foundation for Mental Health, and that's something that we don't discuss much in this room, and I think it's very important. He was responsible for an active author on the national report on the burden of mental health and its impact on economic inequities in the United States, and also an advisor to the CDC. And in that context, he's also been assigned to a specific committee assignment of health equity in the workforce as related to mental health issues. So we're talking about somebody who has high focus on issues very pertinent to us that we don't normally deal with. So I'm anxious to hear, Octavio, your presentation.
Sorry, just one minute. I clicked at the end. Give me 1 second. Helps if we start at the beginning of the presentation, doesn't it? Oh, do you need the notes? The notes that are digit? Do you need them up?
Unless you want Sunshine to present again. That's not me.
Oh, geez, forgive me.
Sunshine, you're back up.
Sorry. Forgive me, I mean,
It's all right.
clearly my coffee hasn't set in yet today. Forgive me. How
That's
did
okay.
I just put Sunshines in there?
Oh, you went to the top.
I went to the
There
wrong
it is.
place.
There you go.
Forgive me. Jeez.
You're just testing us.
Yeah.
There you go.
Do you need the note? You don't need the note setting?
No, I don't need.
Okay,
notes.
so I'll
I
just
have notes in there.
switch it over so that everything,
There you
and
go.
you just press the right hand side. I apologize.
Right, the right-hand side?
Yeah.
All right. Okay, thank you. Well, Bill, thank you for that introduction. And I'm hoping that my presentation today is a great segue from the panel we just had, and definitely from the questions I heard. I think we're in good stead. One thing I will add, in addition to what Bill presented of some of the work that I'm doing, also, I'm on the board of the National Hispanic Council on the Aging and also former chair of the board. So just want to put that out there that I have a long-term interest when it comes to policy work and how it affects our elders. So I'm going to start with this. I want everyone to really start thinking out of the box, put on your policy hats, dust them off, because a lot of you are researchers and I know you often don't dwell in that arena. But I think it's very important, especially based on the questions and the panel that we just had. So I'm going to start with this quote. And I'm going to pose the question to see if anyone recognizes who maybe actually said this. I run because I'm convinced that this country is on a perilous course. I have seen the inexcusable and ugly deprivation, which causes children to starve in Mississippi, Black citizens to riot in Watts, young Indians to commit suicide on their reservations, because they lacked all hope, and proud and able-bodied families to wait out their lives in empty idleness in Eastern Kentucky. So I want you guys just dwell on that for a minute. That was made over 50 years ago by Senator Robert F. Kennedy. Why did I bring up that quote? I think one, it exemplifies that we still need to make tremendous progress when it comes to dealing with what is now what he was putting in that speech of his, the social determinants of health. And also, that was the statement he made in 1968 in Washington, D.C. to announce his presidency for the United States. After he had come back from California and visiting with who? Yes, Cesar Chavez. Cesar Chavez, if you remember, had a huelga going on. And he, in fact, was on a hunger strike and refused to end the hunger strike until someone of authority, and he pointed out Senator Kennedy, would come to visit with him, and he did. And it was shortly thereafter that he decides he's going to run for the president. Before that, he denied it and said he would not. My point being is the Latino Hispanic voice is powerful, and when brought together and makes demands, can in fact make changes. So pre-COVID environment, right? Hopefully most of these statistics you are aware of, but it's always good to revisit and to know what is our baseline, where have we been, where are we going, right? Well, one of the things is we know demographically what has been happening with the Hispanic Latino population. It has been growing and increasing here in the United States. As you can see here, and it's been stated by other presenters, you know, what those percentages are. Overwhelmingly Mexican American, even though that percentage is decreasing over the course of time, as other groups are migrating to the United States, especially from Puerto Rico, which has been mentioned, as well as South America, and especially even Central America. But look here about what's happening with our 65 plus population. In 2019, we represented 9% of all elders here in the US. And it is predicted by 2060, we'll be 1 out of every 5, or a little over that. That is a huge percentage, folks. And it is not a significant amount of time. That is just around the corner, if you think about it. 2060 is not that long from us. And so are we prepared? Well, the answer is no, because we are not even prepared just for the aging of the US population, even though we have known it since the very point in time that we identified the birth of one of the largest cohort in the United States, the baby boomer generation. So don't tell me we didn't know that it wasn't coming. The baby boomer generation, once they were born and during that period of time that they represent, We knew when 65 years later was going to come. And what have we been doing? Dawdling, doing nothing. Educational attainment. That has been referred to as well. And it is extremely important. It really is. Because take a look at where we are. As of where the top is all adults. So you can see that Latinos are lagging far behind. Only 1 out of 5 of us is getting a bachelor's degree. And you can take a look at there in 2020 data that 63% of Hispanic Latino Americans 65 and older finished high school, compared to 89% of all olders here in the US. That has been increasing slowly over time, but we still have a huge disproportionate disparity to address there. And when you take a look at bachelor's degrees, only 18% versus 33% of all elders. Now, why is this important? Well, I'm pretty sure you can figure that out, especially since I'm talking to an educated population. You are falling in that category that actually is in the 20%. Some of us are also in the 18% category, right? Well, 65 and older. Not quite there yet, but I will be. Which is also an important thing of why we need to be looking at that, because all those young adults one day will be elders. Because it also impacts, as we know, education and income in a capitalist society like the United States. Look at the income disparity that we have here as of 2019. 56,000 versus non-Hispanic white population, which is 76,000. That is a significant portion. And that is income, right? The money that you earn, the money that you take home. But then we take a look at, what about households headed up by 65 plus? It's a little bit lower, about 51,000. So it's even lower than the average for a Latino household. And so it's no surprise when you take into consideration educational attainment and how it is connected to how much you're able to earn and probably the jobs that you're able to acquire and qualify for, that we have a huge poverty rate, and especially for our 65 plus population. Over 17% versus only 9% for all older Americans. So debt and wealth also then come into play. Because income is one thing. You can make a lot of money and still have no wealth. Because what is wealth? Wealth is about having assets. Wealth is where actually you have true fiscal and financial resilience. It is not your income. Your income is what's disposable, what you're able to spend, how you take care of the day to day. But if you're not able to build up wealth, then you're not actually making resilience for your family financially. You can't pass it on to your children or your grandchildren because you don't have any wealth, even though you may make a lot of money. Somebody can make $1 million, but if they spend $1 million, they haven't built up any type of wealth, right? Or equity, as we call it. And where in the United States is most equity held? Home ownership. And once again, take a look where we are. We lag far behind when it comes to home ownership. As a matter of fact, Dr. Vega has pointed out several times today and yesterday about the fact that, in fact, we don't own homes, we're having to rent. And what are happening to rents? They're going out the roof. So what is happening then to that income that I was referring to, which was already behind the 8 ball? It's being siphoned away and not being able to be used for taking care of oneself. And so it's no surprise that inheritance rates are extremely low for Latinos. Look how low it is, 5%. 5 out of only 100 Latinos and Hispanics in America are able to pass on any kind of assets to their children. That is abysmally low. And even though the debt level we have is lower, it's all relative, because if you make less, then a greater percentage of what you earn is being used to actually service that debt. And once again, you're actually scrambling, trying to stay afloat financially. So let me move on now to other key factors that existed pre-pandemic, because we've already been discussing, and I've heard the folks out there talking about how the pandemic has impacted us. The pandemic didn't create anything new. What it did was it exposed and made things worse that already existed. As an example, and I start with this one because of who we are as researchers, the current science base is derived from research primarily involving European origin populations. Even today in the 21st century, we're still not on par or equitably including Hispanic and Latinos in research, let alone including across the lifespan, i.e., how many elder Hispanic Latino Americans are being included in the research that is needed to be able to come to the conclusion where we can make generalizations and interventions and translate that research into actual clinical as well as public policy. Work to be done. There's a lack of linguistic ability or interpreter support in this country. It's ridiculous. Last century, we came up with the class, the cultural linguistic guidelines. We've even actually updated them. We know what to do, but the political will isn't there. And what's interesting to me is I'm not quite sure why we, the Hispanic Latino, the largest minority population in the US, allow this to continue to happen. In our emergency rooms, in our hospitals, in our clinical settings, too often still, they turn to our children to translate for us. That is wrong and we know it. And yet we still allow it to happen. And there is no excuse, oh, it costs too much. Oh, give me a break. Do you realize that the healthcare industry is a $3 trillion industry? And multiple studies have been done from Harvard, Hopkins, you name it, across Stanford, in reference to economics, that of that 3 trillion, 1/3 is wasted. So you take $1 trillion, give it to me and to us, and we can fix this whole system easily. That's how awash we are in money. But we are not strategically or effectively, in fact, investing in the appropriate things that we should be doing. So the money argument doesn't fly with me. By the way, before I became a physician, I was a commercial real estate banker. I have a finance degree and an MBA. So when I come and talk and look at the statistics and the budgets and the numbers, I know where I'm coming from. So I know where we've been and where we can go. Many racial and ethnic minorities are wary of accessing care to prior experiences because of historical misdiagnosis, inadequate treatment, and lack of cultural understanding. Is it no surprise? We are well versed in why this is the case, but it has impact, as we were just talking about in reference to the pandemic. Ageism hurts, and it hurts, and it causes death. Ageism is a problem that we have in this country. It is a problem culturally of the United States. We're very youth-oriented. But yet in the Hispanic Latino culture, we do value our elders, but we are acculturating and get influenced by the larger culture, and it over time has impact. So we need to be wary of that and take away what is good and not fall into the trap of also coming into and accepting ageism as a given, because it shouldn't be for anyone. Because Becca Levy out of Harvard has done some very interesting studies and where she has shown that just the perception, how we think about and approach the idea of old age, in fact, can take away or add 8 years to one's life. Who of you would like to give up 8 years? I know I don't. That is, you can do a lot in 8 years. And then we can see there in the last bullet, in 2018, life expectancy, as has been pointed out by our researchers here yesterday, that in fact we live longer. But what is the quality of that life in the later years? That is something that we definitely are all identifying that we need to work on, because we actually are still doing quite well. However, as was just pointed out, though, we've taken a huge dip when it comes to life expectancy. And it's been disproportionately heavy on the Hispanic Latino population. So it'll be interesting to see when the more updated statistics say, take a look at 2020, 2021, and 2022, where we are in reference to this statistic from 2018. And I fear it's not going to be good. COVID-19, it's already been pointed out, and I already stated, that the pandemic revealed deep-seated inequities in healthcare for communities of color. It amplified social and economic factors that have been contributing to our poor health outcomes for decades now. We are more likely, we Hispanic Latinos, to be uninsured, underinsured, or to have a usual source of care. Substantially lower access to care, mental health and substance use services. But here's the rub. Even when we do have access, the quality of the care is not as evidence-based as it is for the non-Hispanic white population. So it's a double whammy. It's insult to injury. We can't get access, and then when we do, we don't have the same health outcomes. We still have disparities. Much work to still be done. We're more likely to work in service industries still. A lot of it going back to the statistics I show of what kind of education do we have. It does dictate often what it is you can work in, what industry. And we're particularly at risk for then loss of income and not amenable to working from home. I am privileged. I was able to work from home, still continue to. Now I have a hybrid model, but that is not the case for a lot of my Hispanic and Latino colleagues. It has been stated by some of the researchers more likely to live in multi-generational low income or public housing across this country. So therefore, when we came out with the initial guidelines, I was asked and appointed by President Biden to be on the Presidential Commission on COVID-19 Health Equity Task Force. That was one of the things we first brought to the President and to the Vice President of the White House, the disparate way that things were being rolled out. They weren't taking into consideration the communities and how the impact of social determinants determined if you're even able to access the services that are being rolled out. Over the course of time of that year, they started to make changes where, as an example, they had the very large, centers for saying, come and get your vaccine, and it was only in one spot. But it didn't take into consideration that it was done during the day when most of us were working. It didn't take into consideration the transportation that was needed to get there. It didn't take into consideration the fact that how are we going to be able to get someone to take care of our children, especially those that were taking care of kids at home or their elders or anyone else maybe who's dealing with a disability. It also didn't take into consideration, even though they said that there were apps that could be used to make the appointments, that the apps were actually designed for laptops and desktops and didn't work all that well on mobile devices. I mean, it was one thing after the other. But if they had actually come to the community and brought us in early and said, how should we design this? We could have told them. It's not like we don't know what the process is to do this. And yet those mistakes continue to happen. Why? Power and privilege. They don't have to think about it. Why? Because representation in the decision-making pods does not include enough communities of color, especially Hispanic and Latinos. And also, as you can see, transportation has been also continued to be a major issue. And this doesn't take into consideration geographic zones. Rural America, where a great deal of Hispanic and Latinos now live, and the challenges that they were having to deal with. The impact, as we know and has already been stated, everything from isolation, loneliness, financial impact, limited access to transportation, healthy foods, affordable housing, all of these have come to bear during the pandemic and have impacted older individuals, Hispanic Latinos, disproportionately. Social isolation, as we well know, has increased the risk of heart disease, which was already mentioned by one of our colleagues, infections, depression, cognitive decline, and yes, death. And of course, as the statistics were brought to us by Del Rios excellently so well, how we've had more cases than the average, more hospitalizations, and more deaths. And it continues. Getting to the point of this pandemic is not over. On average, 400 to 600 individuals a day are still dying from COVID. And a large portion of them continue to be Hispanic and Latinos, disproportionately. We are not anywhere near done with the pandemic. We're struggling to try to just go into endemicity, that transition. And so that's why this continues to be so important. And in fact, and many of us in the public health arena are talking about, it's a syndemic. It's not just a pandemic. Meryl Singer, I don't know if you guys are familiar with her, but in fact, has stated the concentration and deleterious interaction of 2 or more diseases or other health conditions in a population, especially as a consequence of social inequity and the unjust exercise of power coming together. So we had mental health inequities prior to the pandemic. We had structural racism prior to the pandemic, and then the pandemic showed up. SARS-CoV-2, COVID-19. And that's why these statistics are so dire of what is happening, why the effects of the pandemic have in fact hurt our population so badly. It's because we are experiencing a syndemic, and so are other populations of color here in the United States. And when we try to address and bring these issues up, there's been great resistance by the population at large, as we have all seen as well. Well, let me now transition to approaches and solutions. So we all kind of know it's bad and things have gotten worse, and we're in a very unique transitional stage, I think, here in the United States. When you think about us from a healthcare system, which is fragmented and has not had equitable outcomes for Hispanic and Latinos, as we think about the political environment and what is happening in, unfortunately, red states versus blue states, as we think about the elections that are coming up and the impact that will have if, in fact, Congress becomes more red than it already is. If you think that the recent Supreme Court rulings were something now, wait till, in fact, they have all of Congress. It will only become more dire for populations of color. And that is why health equity is something that we need to keep top of mind, where everyone has a fair and just opportunity to be as healthy as possible. But how are we going to achieve health equity? It's one thing for me to state it, and this is, of course, the definition by the Robert Wood Johnson Foundation, who's doing a tremendous amount of work in health equity and with populations of color. But it's another thing to operationalize and ensure that we, in fact, are making the types of investments, the type of changes that results in better health outcomes. Because I say health equity is all about quality. If we don't have quality of care in this country, we will continue to see the historical inequities, disparities, and outcomes that we've been seeing, which are unacceptable. And we must remember within equity that culture and healthcare factors continue to be extremely important. Culture works dynamically in conjunction with economic and social factors in the way that it plays out in the community and with an individual. It does affect our health behaviors, how we see the world around us, how we make our choices. And what we like to do in the United States is we like to say, oh, it's an individual decision. Put the blame on the individual, because that way, society doesn't have to look at itself. Society doesn't have to look at the structural issues that are behind the decisions that are made. Granted, we all do make decisions on our own behalf, but we are often unaware of the influences that then results in the decision that we do make. And hence, those decisions will either diminish health disparities or, unfortunately, worsen them, as has been the case historically. One of the ways is, and it's already been kicked off, I'm also, I should state full disclosure, I'm also on the board of Trust for America's Health. TIFA, Trust for America's Health, is the premier public nonprofit inside the Beltway in DC. So we do a lot, the organization does a lot of work with Congress and with our stakeholders in reference to how to improve our public health infrastructure and system. I'm there because I really want to bring the Latino voice, but also the voice of mental health, being that, of course, that I'm a psychiatrist. But one of the things that TIFA has been working hard at, and other wonderful organizations, such as the John A. Hartford Foundation, is really changing that culture that we have of seeing only the United States as a young-oriented society and recognizing we are aging and we ought to respect our elders. The wisdom that they have, the sacrifices they have made, we stand upon those and do greater things, but only because of the hard work that they did. And so we must improve the care of older adults everywhere they receive care, from hospitals to primary care to the kitchen table. Let us change that culture in general with 3 main principles. Adhere to evidence-based practice, because evidence-based practice shows what we should be doing. but we need to operationalize and implement, and in many cases, translate your research. Reduce harms through reliable implementation across all settings of care, and deliver that care consistently with goals and preferences of the older adult. But another caveat is we must also do it through an equity lens and through a cultural linguistic lens as well. That's the healthcare system. Let us not forget, though, about the other one, which has been extremely dynamic and important and is currently under the gun here in the US and has been decimated in many places. The public health system must also be age-friendly. Public health interventions that optimize the health, mental health, and well-being of adults 65 and over. Because this is when we really start talking about prevention. We must prolong their independence. We know this. Reduce their use of expensive healthcare services will follow if we, in fact, have a healthcare system to help individuals and communities to not only prevent, but to also avoid certain chronic illnesses and promote health equity. But once again, we must do it through a cultural linguistically centered lens. And it's been stated before, but I must state it again because I think it's such a huge part of how we can do this. We must remain community centered as well. Community engagement is critical. The principles of community engagement bear on the work that we do and how we can roll out these policies. We must understand the history of communities. And one community is one community's history. Each one is a little different. And there is nothing wrong with us being able to have, and we have the wherewithal to understand and have the flexibility that there is commonality across communities, but there's also individual variables that make them unique. But we got to understand their history. Recognize and acknowledge the cumulative impact of stressful experiences and environments. That was very clear in the presentations about Puerto Rico. Recognize the role of power and privilege. It is the only way that we can move forward. That's a hard discussion to have with colleagues that are non-Hispanic white. But it is the reality of this United States. As much as they want to whitewash our education and they want to burn books and remove them from our libraries and from our schools, the history is still there. And we must continue to fight and include and realize by learning our history, by knowing where we have failed, we can learn and supersede and succeed for all. Create an environment for public participation, even for our elders. One of the things that I like about NACOA, the National Hispanic Council on Aging, is they have a program that they empower elders to become leaders of their own community. 65, 70, 80 years old for the first time ever, going and talking to their councilman, going and talking to their congressman, getting the skills they need to be able to advocate on behalf of themselves, their family, and their community. You're never too old, never. This whole thing about old dogs don't learn new tricks, baloney, throw it out the window. Why? Because we have the cognitive ability, we have the plasticity to still learn, no matter how old we are. However, as you guys are very concentrated on, we need to find out what those risk factors, diminish those so we can ensure that we have fruitful, long lives. Do not blame, I already mentioned about, don't blame the individual or groups for their disadvantaged status. Also, strengthening the social fabric of neighborhoods is very important. Also, very difficult work. By the way, each one of these points is not easy to do. That we understand, but we should do it because it is hard, because the results of what will happen are worth it. Include all age groups, because that's what our families are doing anyway. They're blended, they're intergenerational. We have grandparents raising grandchildren and great-grandchildren. We have young adults who in fact are taking care of elders. We are doing it all. And understanding that intergenerational strength will allow us to, in fact, to recognize, but also to come up with new solutions. And the solutions are in the community very often. Work across multiple sectors. One of the things that we have to fight here in the United States, and probably it's an international issue, is the silo effect. It happens even to us individually. That is a tough one to do, but it can be done. We must continue to reach out, to cross-collaborate, bring systems together, look at things from a cross-system standpoint. Focus on community determinants through a health equity lens, I think I've already mentioned. Measure and track the impact of social problems, and build on the strength and assets of a community. We must no longer look at communities as deficits. We should look at them for what they are, which is from a strength-based perspective. Because where we need to go, this is my vision, and I want it to be all of ours, a seamless integrated health, mental health, substance use care delivered in a culturally, linguistically, person-centered framework at the individual, family, community, practice, system, and workforce level. Must be cautious to not oversimplify the values, customs, and beliefs that characterize any group, especially one as heterogeneous as ourselves, and practice cultural humility. Encourage an open mind and recognize that each of us sees the world through our own very distinctive cultural lens. So I'll come full circle, and I'll leave you with these two quotes. Some men see things as they are and say, why? I dream things that never were and say, why not? And Dr. Martin Luther King in 1966 to the Medical Committee for Human Rights rings true then, and it rings true now. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Some additional resources, and I thank you.
You want to stay up here, you can answer the questions.
Okay.
You have to answer our questions.
Okay.
We want answers here. Well,
my best.
all right, so we'll have we have time for questions. I would just like to take the prerogative as the moderator here to ask you the first question, which is, and I keep asking this every time I do a presentation of people, especially you, because you did such a wonderful presentation, and it's a 360-degree review. To what extent do you really believe that we can reduce health equities without improving the socioeconomic status of Latinos? An easy one.
Oh, I know, Dr. Vega gives the easy questions. No, that's a complex and difficult question, but I'm going to give you the truth. Truth is, if we don't get the socioeconomic status situation in the right direction, we will not. It is the truth. And that is what needs to be relayed and conveyed to our populations to truly understand the importance of not only hard work, because boy, if you want to choose, and I know I'm being biased here, and I'll take that up front, but an industrious group of people, Hispanic and Latinos, immigrants that come, what are the first thing they're doing? They're working hard. They're entrepreneurials, they're putting businesses together. But they must not also forget the importance of education. And especially for those that have been acculturated or several generations in, why have we not made the gains? And if we don't make the gains in education, we will stay where we are. We will remain disparate, where we make 20,000 less than the average white American in America. We will remain unhoused. We will remain unwealthy. We will remain without equity, which means that we will have no power. And in fact, we're the largest, minoritized group in the United States. We have the potential for great power, but we haven't been able to bring it together. And if we don't do that, we won't achieve what you laid out.
Yeah. Okay, other questions now besides mine? Okay. Gladys. Is there another, is this the only microphone?
Well, there's another one. We'll work with this one.
Okay. Yeah, why don't you stay
Okay.
Thank you. It was
I'll stay up here.
inspiring, really inspiring.
Thank you.
But it's also, I feel uncomfortable more than usual. Because then I'm a researcher. And what do you think really our role can be? I mean, really millions of hours, lives are, besides dollars, we invest in our research. And it seems like really doesn't matter. It seems like nobody cares in general.
for this population. So that's one. But what do you think really our role ought to be? The second has to do taking advantage of your, because you care a lot about mental health. Somebody told me once in one of these academic meetings, the problem with Latinos is that, they're sick, traumatized, depressed, and they don't even know it. So the leadership comes by with this thing of, and I felt very offended at the time. And I heard that in a very subtle way, as a way of prioritizing our opinion. So I wanted to pick your understanding on how can we really put this mental health of Latino population in perspective when we are doing community action.
No, excellent, very excellent question, and really good thoughts for us to have and to canoodle together here. One thing that it comes to mind, and I did it on purpose, bringing up the 1960s, a time of great tumult in the country, but also was a time of great coming together by groups, especially Hispanic and Latinos, LULAC and all that. Advocacy was huge. But we had one thing, and I was talking to Bill about this yesterday. We had leaders. We had individuals like Cesar Chavez. We had Dolores Huerta. We had folks that were willing to take the hit for everyone. But how would they do it? How would they make progress? And they did make some progress. They got attention. Now, one can argue, and I think it'd be a good argument about sustainability, but that's where it comes to the discussion Bill and I were having yesterday is there was a group of leaders that came forth in the 60s and early 70s. And Bill was part of that. But where is the leadership now that should be behind them? What we thought was it was going to be like a cone effect. There were a few, but we were going to bring forth younger folks to be part of that advocacy and move things forward. But it hasn't happened. Very interesting. Is there the lack of voice out there? I mean, these assassinations, they had an impact of who was taken out, right? But that was a while back. So what has been happening in the meantime? Economics, because this is a capitalist society, and those with power and privilege know how economics works. And how, in fact, over the course of the last 50 years, we've been disenfranchised and didn't even know what was happening because it was so insidious. Little at a time. Don't give workers increased wages like it happened in the 50s and 60s. You know, people today, well, not exactly today, but let's go back pre-pandemic. Their wages per capita were worse than they were in the 50s and 60s when you take into consideration how much inflation has occurred over the course of time. But what has been, and buying into work harder, and you will be able to, advance. Well, you can't work harder if the system continues to up the game on you. You go from one job to two jobs. You can have three jobs, and you're barely going to still be able to make it. That is one way to keep populations of color in their place. Because I'm sorry, and I'm going to say here in the United States, those of power and privilege, what they saw in the 60s and 70s, they didn't like it. And by the way, they've been strategic in how to ensure to keep the population from actually becoming more educated. They're attacking our educational system. Public education has been one of the most important concepts of the United States. And right now, it is under attack because they know how to manipulate individuals to think that public education isn't serving their needs. Because what you do is you create an environment where education doesn't serve your needs, and then you tell people, see, it doesn't work. How do you do that? You starve it of resources. How do you do that? By telling people, hey, your taxes are too high. Let's cut your taxes. Instead of folks sitting down and realizing, wait, my public taxes are used for the education of my child. My public taxes are used for the streets that are created. the water, the electricity, the bridges, the parks, which are all social determinants that everyone benefits from. Now I start there because understanding the environment, the contextualization of what we all work and do goes to your question. So as a researcher who is way down and doing some really important specific work, what can you do within that kind of environment? It feels overwhelming, right? Because the issues are so complex and grand. But what, and it was stated earlier, what by Dr. Del Rios, what you have is data. They don't like data because see, without data, they can say the problem does not exist. With data, it's hard to ignore. Now they're still going to attack it, but you stand strong. Your methodology is strong. The integrity of your research is good. The results show what is happening. It's also then going back to where I started. You need to also become an advocate. You can't just be a researcher anymore. This is a very complex world. That doesn't mean you yourself have to go and meet with folks, even though it'd be powerful. And you start where I would say you're more comfortable. If it means going and meeting with your city council or your local county to make things done, start there. Or your own organization. How is the hospital system I work for dealing with these issues? Find allies, other colleagues, regardless of race of ethnicity, to join you. Because the more people in a voice, the greater it's going to be heard. And especially if you can also make it multicultural. And yet you can still achieve your goal of improving Hispanic and Latino health. Taking advantage and going to your state house, your capital in your state. Often they have white coat days and this and that. Well, why not create a research day? Why don't all researchers come together and go to the capital of every state? And you can actually come up with an agenda and meet with folks and let them know this is happening. What's important, and they do listen to this. And by the way, Texas is where I'm from. Tough as nails, right? But the Hog Foundation, we take the approach, my policy unit and myself, to meet with political leaders, no matter who they are. I don't care if they're Tea Party, I don't care if they're Republican, I do care if they're Democrat, progressive, but you have to go with thinking of the higher cause, the agenda and the education. And here's the thing, politics is a long game. You know, you may fight several times over the course of several legislative sessions, and you think you're not making headway, and then bam, 4 years later or 5 years later, you've got a bill. That's the other thing, this is a long game. Because sometimes we get so involved with the short game, we can't see beyond the forest because of the trees, right? So I know it's tough, but those are ways that can be done. The other thing that you have is another voice that isn't used by researchers as much as it's used by others. I do a lot of op-eds. Write op-eds. Get it into the public. You also have social media. Social media has been used to mischaracterize. Social media has been used to put out false information. We'll use social media to do the opposite. Put out the truth. Band together and bring it together. Also, let us make it cross-generational. How do you get young adults and youth involved? Because they're hungry for it. At least in my work and down in Texas, it is amazing how much we're able to do with our youth now. And they are different than we were. They're much more into advocacy. They much more understand the social determinants that are impacting us. They understand and are willing to accept intersectional variables that we didn't initially, as well as what's happening to the environment and climate change. Get their voice in there. Because when you go and talk to someone that has been elected, if you bring a constituent, if you are a constituent, like it or not, they know you vote. Like it or not, they will listen. Will you change their mind? Not necessarily. But you've got it on the table. And you'll meet with them again and again and again until you're able to maybe come to a meeting of the minds of how to move things forward. The power of negotiation is very useful. But if you don't know how to negotiate, then you need to pick up that skill. Take that class. It will help you in the long run. It also will help you in your personal life, by the way. So negotiate for buying a new car, buying a house, things of that nature. I taught leadership and negotiating skills to psychiatry residents in San Antonio. I have some great stories about the residents coming back and going, oh my God, I couldn't believe that I got the car for da-da-da-da. I said, yeah, all you got to do is ask. Don't always accept the given. So I know it's not a clear-cut answer, nor it is a smooth one, but it is a path. And as you start to make progress and you start to find out other allies, and also expand outside of your research bubble in some cases, or environment, like we're doing here, making those connections, but also making it within different arenas. Find out who, as an example, imagine in the private sector, a local corporate individual who is well thought of, who maybe agrees with your approach and research, not asking for money for the research, but actually informing them and having them be an ally. So then when you do go and talk to, and we've done this as well in Texas, and it has good effect, where you're going and talking to our policy stakeholders and elected officials. If you have the CEO of blankety blank, XYZ corporation, oh, they stand up. And then don't forget the power you have because of the alphabet soup after your name. MD, PhD, MD, PhD, Masters of Social Work. You're professionals. Your voice matters. It does have power. And one way to start it is to believe in your own self and know I do have power. And when someone tries to shut you down, you go, no, no, no. I have the data, I have the knowledge, I have the skills. I am an expert. Are you? We allow other individuals often to put in our own minds the doubt, and we take ourselves out of the game. Don't do that. Don't let anyone take you out of the game. Stay in the game because you're there for a greater cause. So I know it's not a perfect answer, but hopefully there's some tidbits in there you can take away some pearls.
Thank you so much, Otávio, for that inspired conversation today and for the keynote speak. Please join me in thanking Dr. Rob Martinez.
Can I have one with Bill? Bill, introduce me. Gracias, carnal.
All right, everyone, thank you so much for keeping with us. I'm gonna call, as we set up the next section, I want you to look at the center of your tables, where we have the evaluation forms for the conference. Please, before you leave today, I'm asking you to complete these forms. We also going to send them online for those of you that already left, they're not here today, by email. There's a form here on the corner. It's here. It's also taken. Thank you so much for your participation. Thank you so much. I was trying to find it. That's great. But please complete your form. There's a little box here at the corner that's like kind of orange color for you to deposit your evaluation. That's very important for us as we plan the next year of this conference. And we apply for the grant for the continuation of this year. So please don't get this out completing this form here for us. Also check your junk mail. Some of you might not be receiving our emails they come from Common Ground scholars. So please check, and if they are there, you see that actually we have several communications for all these months, and some is still going to come in the coming months, so please check it. At this moment, I would like to start officially the paper session 6, Resilience Interventions in Technology, and I'm going to invite the chair, Monica Vela from the University of Illinois College of Medicine, to make the introductions of the group.
Sorry, just one moment.
Thank you, Monica.
Yep, just one second. They're just going to introduce you first.
Good morning, everyone. My name is Monica Vela. I'm the director of the Hispanic Center of Excellence here at the University of Illinois. I'm an internist, Chicago born and raised, 2 Mexican immigrants. And I want to thank Dr. Martinez for fueling not only our inspiration, but a little bit of rage over the structural violence that Hispanics face in the United States. Over the next 15 years, we will face an incremental demand of over 50,000 physicians to provide care only for our growing and aging Hispanic population. The University of Illinois has graduated 200 Hispanic physicians in 10 years from 2009 to 2019. And we are the institution that has graduated the most Hispanic physicians during that time, more than any other medical school in the contiguous United States, and more than even some of the schools in Puerto Rico. It is not enough. It is not going to be enough. We need to do more, even though physicians are just a tiny part of what we need to get done to improve health equity for Hispanics. I'm really excited about this panel coming up. Our very first speaker is Dr. Susan Aguinaga from the University of Illinois at Urbana-Champaign, speaking to us about the Mediterranean and Mediterranean DASH intervention for neurodegenerative delay.
All right, good morning, everybody. Thank you for the organizers for inviting me and for putting on such a wonderful conference. It's been a really great experience. So we're going to switch gears a little bit and we're going to talk about dietary patterns and its association with executive function and psychological distress among Latinos. So content warning, some of these images may induce hunger, so I apologize for that. All right, so we already know that the older Latino population continues to increase, and we see health inequities among Latinos, such as having increased risk and prevalence of chronic diseases like diabetes, obesity, and hypertension. And they are more likely to have multiple chronic diseases compared to non-Latino whites. So these chronic diseases, in addition to other factors like socioeconomic status, environmental factors, structural factors, put Latinos at increased risk of developing Alzheimer's disease, such that Latinos are 1.5 times more likely to develop Alzheimer's disease compared to non-Latino whites. And so currently 12% of Latinos are diagnosed with Alzheimer's, and this number is projected to increase by 832% by 2060. Now, 1/3 of Alzheimer's disease related cases worldwide are estimated to be attributable to modifiable factors like diabetes, obesity, and hypertension. So Alzheimer's is a complex multifactorial disorder, and we need interventions that target several risk factors so that we can achieve optimum preventative effects. So we know that following an overall healthy diet is a recognized strategy to prevent cardiometabolic risk. And in general, systemic reports of diet quality by ethnic background are scarce. However, the little data that we do have shows us that Latinos have a lower diet quality compared to other races and ethnicities. From the SOUL study, we also see that Latinos have a high consumption of sugar-sweetened beverages like Coca-Cola, low consumption of whole grains and fruits. However, from the SOUL study, we also see different subgroup differences. We see that Mexican Americans have a higher diet quality, while Puerto Ricans may have a lower diet quality. Now, because individuals consume meals that contain a variety of nutrients, there has been an emergence of research investigating the potential synergistic effects of dietary patterns on health. So, for example, we have the Mediterranean diet, which is characterized by a high consumption of fruits, vegetables, and olive oil, with a moderate consumption of alcohol. And it's been associated with increases in global cognition and episodic memory and fewer depressive symptoms. We also have the MIND diet, which is the Mediterranean DASH intervention for neurodegenerative delay. And this is a combination of the Mediterranean and DASH diet with modifications based on the most compelling evidence in the diet dementia research. And so observational and longitudinal studies show that individuals who adhere to the MIND diet may have a reduced risk of Alzheimer's disease. Now, there are very few studies that have assessed dietary patterns among Latinos. So in the SOUL study, they assessed the DASH diet, and the DASH diet was developed to control or prevent hypertension. So among 10,000 Latinos, we see that Latinos have a mean score of 34.3 on the DASH diet, and the DASH scores range from 0 to 80, so a little bit on the lower end. There was another study that was conducted among Puerto Ricans, and they assessed the MIND diet among 1,500 Puerto Ricans, and they had a mean score of 7.39, and the scores range from 0 to 15. So again, scoring a little bit on the lower end. So now we may be seeing these lower adherence to these dietary patterns for a variety of reasons. So it may be that the food frequency questionnaires that are being administered may omit or may misclassify traditional elements of Latino diets. But something I want to highlight is that some of these dietary patterns that are often promoted are not culturally tailored for Latinos. Now, given the risk in chronic disease and Alzheimer's disease among the Latino population and the limited data on dietary patterns among Latinos, we conducted a cross-sectional study to investigate the relationship between different diet indices, particularly MIND diet and the Mediterranean diet, with cognitive performance and psychological distress. So in order to be in the study, participants had to be 50 years and older, they had to self-identify as Latino, and they had to have a score of greater than 21 on the Spanish modified telephone interview for cognitive status. So we recruited from Aurora and Berwyn, which are two suburbs that are west of Chicago, and Champaign, Illinois, which is where we're located. So we administered the Spanish Block 2005 food frequency questionnaire, which is a beast of a questionnaire. It has about 110 food items, and it takes about an hour to administer. And from this food frequency questionnaire, we derived two scores. We derived the MIND score, the MIND diet score, and the Mediterranean diet score. Now, the Mediterranean diet includes the consumption of olive oil, fruit, legumes, vegetables, cereals / whole grains, and fish. And the MIND diet promotes the consumption of 10 food items, a lot of overlap with the Mediterranean diet, but with special focus on berries and leafy greens. Now, something to note about these two diets is that it doesn't exclude any food items. It just asks people to limit meat and meat products, dairy products, alcohol, fried or fast foods, red meats, so a lot of the good stuff. Now, we use the NIH toolbox to assess depressive symptoms, loneliness, perceived stress, general life satisfaction, and this is what we call psychological distress. And in order to assess executive function, we administered the verbal fluency test. So we had 61 participants in our study, 77% were female. They had less than a high school education. We also assessed device-assessed physical activity using a hip-borne accelerometer, and we see that participants in the study had a mean average of 15 minutes of moderate to vigorous physical activity per day, where we know the recommendation is 30 minutes per day. And then in terms of the MIND and Med diet scores, participants in the study had MIND diet scores of 7.9, which is similar to the study that was conducted among Puerto Ricans. And then for the Mediterranean diet score, they had a score of 9.57, and this had a range of from 0 to 17. So in the moderate range for the Mediterranean diet. Now we ran regression models and we controlled for age, sex, and education, and we found some interesting findings. So in terms of the MIND diet pattern, we see a significant association between adherence to the MIND diet and better verbal fluency. However, no significant associations with the MIND diet and our psychological distress variables. Now, when we look at the Mediterranean diet, we don't see a significant association with adherence to the Mediterranean diet and verbal fluency, but we do see a significant association between adherence to the Mediterranean diet and better stress, better life satisfaction, less sadness as well. So greater adherence to the MIND diet was associated with better executive function. And we also see that greater adherence to the Mediterranean diet was associated with less psychological distress. So this may be a function of the different dietary patterns and what it is specifically recommending. So for example, the MIND diet specifically recommends berries and leafy greens. And so these have been associated with neurogenesis. And so that's perhaps why we may be seeing an association with better verbal fluency. Now, I want to highlight that in general, we saw low to moderate adherence to the MIND and Mediterranean dietary patterns. And this may also be a function of using the food frequency questionnaire. Now, we did use the Spanish Block 2005, which does include some Latino food items, but of course, not all of them. So I think in order to address this limitation in the future, other studies could potentially use 24-hour food recalls. I think these findings in general suggest that we may need to recommend specific dietary patterns depending on the outcomes of interest. I think either the MIND or the Mediterranean diet are both really great options. However, I think we also need to highlight that there's a critical need for culturally tailored dietary pattern interventions, specifically for Spanish-speaking Latinos. So given our advanced findings and the lack of culturally tailored interventions that simultaneously target physical activity and diet that aim to improve cognition, so we created OCEAN, which is optimizing cognition via exercise and nutrition. And this is a study that's funded by the Midwest Rabel Center for Health Promotion and Translation. So this is a randomized controlled trial where we're randomizing Spanish-speaking Latinos into one of two arms. The intervention arm is a remote delivered 6-month Bailamos Latin dance program plus a MIND diet curriculum. And the control group receives the 6-month Bailamos Latin dance program plus general health education. So we chose the Bailamos Latin dance program. This is an evidence-based program that's culturally tailored. It includes a culturally tailored Latin dance program for Spanish-speaking older Latinos. And this was created by David Marquez in the audience and a professional dance instructor, Miguel Mendez. And so multiple studies have shown the benefits, have shown that participants who receive the Latin dance program improve their cognition. So we know that this program works. And so now what we want to know is if we add a dietary component, specifically the MIND diet, can we see magnified effects in cognition? So due to our results, we chose the MIND diet, again, because it has the most compelling evidence in the diet dementia research. And of course, there have been several observational and longitudinal studies that show that adherence to the MIND diet is associated with reduced incidence of Alzheimer's disease. Now, I mentioned that we need to culturally tailor the MIND diet. And so that's exactly what we're doing. We develop MIND diet curriculum, and we use surface and deep structure strategies to do so. So the program is actually in its 7th week right now, and all content and materials are delivered in Spanish. They receive 1 weekly 1-hour MIND diet curriculum session. We also provided olive oil and nuts to offset any potential financial barriers. Recipes include typical Latino more Mexican dishes because the majority of our participants are Mexicans or more Mexican leaning, and they've been modified to meet Mind Diet requirements. We also provide participants with different reminder aids in the form of a Mind Diet Loteria card. And so for those of you who may be unfamiliar, this is a typical card from Loteria, which is Mexican bingo, but we collaborated with a artist from Chicago and we developed the Mind Diet Loteria card. And so they get this as a refrigerator magnet, and they get this in a tote bag. So when they're grocery shopping, the hope is that they'll be reminded of which food items to buy. And we tried to tailor the food items as much as possible and include the recommendations instead of for the numbers. Group discussions are led by my graduate student, Juliana, who's in the audience, and she incorporates different socio-cultural values regarding mind diet eating barriers and facilitators. And these not only focus on individual barriers and facilitators, but also social and family concerns. And so group discussions also highlight the importance of taking care of their own health to better care for their families. And again, this is in line with the cultural value of familismo. So stay tuned for our findings. Hopefully we can present them at the next conference. And I just want to acknowledge my team and of course the research participants, and follow me on Twitter. Thank you.
Our next speakers include Dr. Acevedo and Dr. Moyes from the University of Illinois at Urbana-Champaign, speaking to us on technologies to support cognitive health.
Good morning. Well, for those with the program, we usually don't start with an apology, but I'll start with an apology from Professor Andy Rogers. Unfortunately, couldn't be here, so you're getting two speakers with no refund for the price of one, but obviously not Professor Andy Rogers, so we're sorry for that, but at the same time, we would like to thank for the opportunity to speak on her behalf and keep the presentation. So thank you for the warm welcome. When we proposed this talk, as well as the two posters that we presented yesterday, and we welcome everyone interested to revisit, our idea was twofold. One, really to learn more about the specific needs of Latino communities and the barriers, and I think we covered throughout the entire day yesterday a lot of those barriers and struggles of the community, as well as showcase a little bit of what we're doing and with the intention to bridge collaboration. So we're very glad to see a very diverse group and different aspects of collaboration across different universities, across different disciplines, and we are hoping to add the perspective of how technology could support and mitigate some of those barriers and struggles. So we'll divide our presentation into blocks. So across this presentation, we'll focus on a couple of resources and collaborations that we've been doing. The first one being CHART, then we will move to the Life Home. So we'll go over those four types of resources and collaborations, and we will be welcome both if you would like to contact Professor Andy Rogers directly, or as well us at the end of the presentations to expand a little bit more on how to use those resources at University of Illinois if you're interested. So the first idea is CHART. So CHART is a collaboration with Health, Aging, Research, and Technology. And I was really glad one of our keynote speakers, Dr. Martinez, mentioned the importance of bringing community members throughout our research. And the idea here is that when CHART was created, it was really to bridge faculty doing research or traditional inside university walls with healthcare providers and community members. So it's a really great opportunity to bring this triangle and think about fundamental research and how can we advance technological solutions and interventions, but keeping in mind that we're actually doing for someone, so the community already have their practices, as well as what can we receive guidance from experts, in that case, healthcare providers. And we're very fortunate that when Professor Wendy Rogers joined us at University of Illinois, one of her missions was to bridge this space and build this space, which is the McKechnie family donated a lot of funds to create this very cutting edge facility. So the McKechnie Family Life Home, and life here is an acronym that was really thought through this idea of how can we live in interactive future environment. So it's ubiquitous to say that technology is around us, and then we have barriers of using different devices, but it also augments a lot of the possibilities that we have. And a key concept also in our research is to think about aging in place. So a lot of have to do with how can you successfully reach a healthy life in all the kinds of domains, thinking about the spaces that older adults are living. So as the spaces evolve and technology evolve, how can we actually anticipate some of those trends, thinking about interactive future environments? So that's the acronym for LIFE. And what this space really is, and then there are collaborators, not just from University of Illinois, it's a space that you could actually rent to do your experiments. There are two parts of this facility. One is an actual home. So it simulates a 2-bedroom with kitchen and bathroom with a lot of accessibility and interesting questions about aging that could be explored. And in part, what you see, the blue area in the map. So we love orange, and blue is the color of the universe. So in orange, you see this interactive simulation house with bedrooms and living room and spaces that could be adapted and tailored to different research needs. And then the back office, so to speak, the blue area, provides like smart technology, like you could monitor rooms with observation rooms. There's an interview space. So you have the research facility with conference room and all the kind of equipment to conduct cutting edge resources. You would see when George will present the second part, there's a lot of robots, and part of our interest is also how we're going to live in space that includes known biological agents such as robots and technology in general, how we make that transition. And also in terms of collaboration, just to point that historically, University of Illinois has been part of several collaborations funded by NIH and the different institutes within NIH, including NII. So CREATE was created in 1999, and we've been part of different centers such as TaxAge and the Enhance. So if you really want to reach out and be part of that community, if you aren't already, please reach out to Professor Wendy Rogers. But the idea here is that across all those collaborations, I think the common theme is how can we successfully use technology and listen to the communities and engage in using technology to support successful aging. That's the common theme across the three. In some have focus on disabilities, there's a little bit of a different focus in each center, but across all the three initiatives, the idea is to promote collaboration for successful aging. And one thing that I think perhaps we could add to the discussion of resilience is a broad view, and Professor Wendy Rogers has been done a lot of research on, initially I think we have this myth that older adults are resistant to technology and they don't like cutting edge technology, but I think it's important to reflect what kind of activities you want to have less autonomy and delegate to, for example, a mobile. So there's a lot of variation on the adoption from the perspective of activities as well. We cover different aspects, but perhaps we could add to the following joint discussion this reflection. So in one hand, we can think about activities of daily living, like the ADL, so bathing, eating, drinking, mobility. And some of those, we find some evidence that once you try to replace basic functions, usually you create a lot of more resistance because the individual wants to keep that level of autonomy. But when you investigate things that are more instrumental, such as preparing meals, paying bills, managing medications, maintaining the home, there's a lot more acceptance and recognition of value of why technology is important and could help some of those instrumental activities. I'll show in a little bit one example, which is the project I'm involved with, medication adherence. We see a lot of potential for using mobile phones as a way of improving medication adherence for hypertensive medication and so on, right? Other kinds of diseases. And just to connect with our previous speakers, for example, if you're trying to deliver an education intervention, you could also have technology supporting that, perhaps through a mobile app. And then you also have enhanced activities of daily living, such as social communication, hobbies, new learning, volunteering, community participation. If anything good came out of the pandemic, is perhaps this idea that we have to find alternatives to engage with communities vis-a-vis the restrictions of not being able to do it face-to-face. So I think it became at least more salient to the known researchers of how important that could also be to just enhance the quality of some of the social activities, as we've been restricted to do so in a more regular fashion. And just to mention some of those interventions, Dr. Vega also pointed out in the first day the importance of thinking beyond, like, so with the data we collect, how can we actually create interventions and think about moving to a different level of, could be experimental. In our case, the projects we usually involve are randomized controlled trials. So really try solutions and thinking about therapeutics and testing our ideas in that kind of setting. So I'll cover the first project and then I'll pass the baton to my colleague, George. So MEDSRAM stands for Medication Education, Decision Support, Reminding and Monitoring Systems. We often follow the idea of a mobile health application, an iPhone-based application, but we think about it as a system. More importantly, there's a companion website, the elaboration on educational materials and strategies, as well as the instruction guides. A lot of the research on mobile apps pose this idea that if you don't have good instructions and good design, very quickly people disengage with. There's tons of apps, and I'm not going to belabor during the presentation there, but very few have the care to listen to the communities and really engage people in the development of early stages, which also include instructions. So the first part of our lab named Human Factors, for those that are not in the area of human factors, is really this idea of user-centered design and how to use different types of instruments and methods to engage with the user and really making sure that it's usable, right? So perceivedness of use, the technology readiness of using and adopting. So for MEDSRAM, just to give one example, this idea of medication adherence, when you organize around events that are already part of the routine of the individual, the hope is that you would have better adherence. So we're trying to tackle, as mentioned, hypertension is pervasive with older adults, and even more important with Latinos. We saw the discrepancy of the numbers. We're opening, a possibility for future collaborations. Right now, we don't have MEDSRAM specifically tailored for Latino communities, but we're hoping that, as a future grant moving forward, this agenda, we keep showing incremental, bridging it to different communities. And as mentioned, I'll pass to George.
Hello, everyone. It's been a pleasure being here for the past 2 days, and I've learned so much, and it's been so great to get to meet all of you. I'd like to talk a little bit more about our one-click project, which is a research clinical trial. This particular project is focused on trying to understand how can we facilitate social engagement opportunities for older adults with and without MCI. Part of what we're doing, we're offering social engagement for older adults through a video conferencing platform that has been designed specifically for older adults with and without MCI. We have applied human factor principles to design this platform together with a one-click team in order to ensure successful application of the technology. Because one of the things that's often challenging, right, for a lot of technologies is that they're often presented to older adults, but they're not always designed with older adults. And part of what our team aims to do is to always involve older adults within the design process and the development process. This is one of our robotics project, Stretch, which can help assist with some of the things that Renato had mentioned earlier, things like ADLs, IADLs, EADLs, similar to Stretch, soft robotics. And one of the things that we're trying to also understand is how do we implement all of these things within a home-like environment and be able to utilize them? Also, we're trying to understand how can we leverage market-ready technology, such as like the Misty Robot project, which is an open platform and allows users to be able to customize this particular platform to allow the facilitation of either social interactions, to be able to assist with various activities of daily living, independent activities of daily living, and trying to really understand how do we leverage what's already available to help support and meet the needs of older adults. How do we design robots to support health and wellness? And what do robots need to do? First, robots need to communicate with humans and potentially be able to show emotions. They need to perform tasks for persons, be trustworthy. And trustworthiness is very important because it also helps facilitate the acceptance of technologies, right? Because even though we may present the technology, if the technology itself does not get accepted, it does not get used. Have an appearance that people like, provide social support, and enhance cognitive engagement. Now, how do we achieve this? We engage the users. And I think it's so crucial that we try to understand and meet the needs of everyone, right? Because at the end of the day, one of the most important things is will the individuals use these technologies? And do we understand what the users needs? Some of the categories of robotics are telepresence robot, which are the robots that you can see in this corner. We have assistive robots, which is kind of like the stretching to be able to like manipulate environments, mobile manipulators and surveillance with cameras. And then you have social robots, things like Puerto, the baby seal. Soft dexterous service robots configurations to support healthcare for the home of older adults. These types of robots can help provide support with either bringing an object to an individual, help support with specific tasks, and help reduce the strain that individuals may experience. Other robots can help reach and bring the medication to the individual, help support with other types of support. Healthcare providers for telehealth technologies, and how older adults' attitudes toward these technologies is very important because that is also informs their adoption and use of these technologies. But it's also important for us to understand what are the barriers and facilitators of using these technologies within a home-like environment. I think one of the things that we're quickly learning is that the home environment for every individual looks quite different, right? And for a lot of individuals, their home environment, for example, most of the homes are 2 stories. How does that impact the individual's ability to be able to age in place? What are the types of resources and types of technologies that can help support with that? The floors may not be apt to be able to use the technology within the home. How do homes need to be adapted to be able to allow the implementation of technologies? Trustworthiness and socially assistive robots survey. We've done a survey which looks at people's opinions about sociability of different robots and their trustworthiness. And we can definitely see how users' trust also increases with the user's perception of the robot's sociability. So robots that tend to be more social often tend to be more trusted by individuals. Also like to tell you a little bit about the Masters of Science in Health Technologies, Innovating for Health, that's offered through the University of Illinois at Urbana-Champaign. And if you'd like to learn more about this, please feel free to reach to the contact information that's listed on here, or healthtech@illinois.edu. And just a huge thank you for allowing us to be here today. And we're so grateful to be able to have this opportunity to share some of the things that we're doing in the Human Factors in Aging Laboratory, University of Illinois. Thank you so much, everyone.
Okay, you heard it here first. The future is here. Our next speaker is George Reebok from Johns Hopkins, speaking on community-based interventions for resilient aging.
Oh, let me get George up for everyone. All right, one moment. Sorry, George, just one moment while I get you up on the screen here.
No worries. Can you see my slides?
We can see your slides, but not your face. So just give them one and we can. It's nice to have you. I'm just going to remove. I think the problem is that I had you the other person highlighted there. So I'll pin you to the side so we can see you as well. And we should be ready to go. You can go ahead.
Well, thank you very much. I'm really excited to be here today. I wish I could be with you in person. And I'm going to be presenting on the topic of cognitive health in later life and community-based interventions for resilient aging. Before I begin, I would like to thank the conference organizers for inviting me to be part of this very exciting session today. And I would also like to thank the National Institute on Aging for my research funding support, and I have no other relevant financial disclosures. Here is a brief overview of what I'm hoping to cover this morning. I'd like to give a brief overview of community-based cognitive interventions in later adulthood, particularly those involving minoritized groups of older adults, review some of the evidence for cognitive intervention benefits in preventing cognitive decline and dementia, and promoting resilient cognitive aging among diverse older adults, and then look at some future directions in the field. So let's begin with a question. Why is cognitive intervention in later adulthood important? We all know that the older population is growing rapidly and becoming more diverse. There is also evidence from numerous surveys that dementia is a feared aspect of growing older. In this survey cited here by the Harvard School of Public Health, it was second only to cancer in being most feared. And the drug trial results to date have been very disappointing. And we also know that cognitive impairment heavily impacts on the aging population. About 5.7 million people in the United States have Alzheimer's disease, and that's probably an underestimate. And as been mentioned, African Americans, Hispanics have rates of AD 2 times and 1.5 times higher than non-Hispanic white Americans. And these disparities have persisted for past several decades, and in fact may even be becoming larger. So it's no surprise then that cognitive ill health has emerged as a prime target for prevention. And the goal here is to keep people aging normally, cognitively across the life course, even though there are several factors that impact on that age trajectory. But health promotion efforts are aimed at preventing older adults from falling off that course and crossing the threshold into cognitive impairment and MCI and dementia. So at the risk of oversimplification, there are two general approaches to improving cognitive function in older adults. There's cognitive training, which involves direct instruction and modeling of cognitive strategies, performance feedback, and presentation of novel stimuli and practice of learned skills. And cognitive training can be directed at a single cognitive ability or multiple cognitive abilities. It can be given via computer or an app, or it can be delivered in person, either one-on-one or in small groups. It's important, though, to recognize that cognitive training is something more than just brain puzzles or brain exercises. It's a structured program, a structured approach to improving learning. The other approach, in many ways complementary to cognitive training, is cognitive stimulation and engagement. And this refers to non-specific stimulation of cognitive function via engagement in everyday stimulating cognitive, social, and physical activities. In 2017, AARP conducted a cognitive health and brain activity survey. And one of the questions they asked in this survey, and by the way, this survey involved over 1,600 diverse adults age 40 and older who were queried a number of different aspects of their brain health. And one of the questions was how, if you were to improve a specific area related to your cognitive ability, how willing would you be to participate in cognitive training? And as you can see here, the wide majority of adults in this survey said that they would be very willing or somewhat willing, over 80%, to participate in cognitive training. Now, there was some variation based on background characteristics, as you see there on the left, but overall, you get this sense that adults would be willing to engage in this type of training. Now, a separate question is, if they were actually given the opportunity, would they actually engage in cognitive training? Now, Erin Harrell and her associates probed this question a little more deeply and explored the willingness to engage in cognitive training. And they found that older adults who thought that cognitive training was efficacious and who were more open to experience, and those who self-reported perceived cognitive deficits expressed more willingness to engage in cognitive training. It was also shown in this survey that adults age 70 plus are more likely to engage in cognitive training in person, and significantly more African Americans and Hispanic Latinos compared to the general population said that they would be likely to engage in cognitive training in formats other than in a computer. So you see those results here in the circled for each group. Even though all groups were willing to engage in cognitive training on a computer, African Americans and Hispanic Latino said that they would be more likely to engage in person. And many adults in this survey saw the benefit of adding mentally stimulating activities to their routine. And importantly, more women and Hispanics, Latinos saw the benefits to all areas of health and well-being compared to other groups. And so adding stimulating activities was seen as really improving overall resilience, overall brain health, emotional well-being, physical health, and social well-being. This next slide shows the results of a survey of the literature, a comprehensive survey of the literature that was conducted by former PhD student of mine, Marian Zhuang. And it asked the question of the participation of ethnic racial groups in cognitive training. And not surprisingly, there was really an underrepresentation of different racial ethnic groups in cognitive training. There were only few studies that involved Black African Americans, including this active study noted here, which I'll be talking about in a little bit. There was only one study, the McDougall study here, that involved any proportional representation of Hispanic Latinos, and other racial ethnic groups were really very, very much underrepresented. So clearly there's a gap here that needs to be addressed in this area of research. I had mentioned Dr. McDougall's study. This is called SeniorWise, and this is the first and only cognitive training study to date to include a tri-ethnic sample. And then these individuals were followed longitudinally for 2 years. And the cognitive training in this case was culturally adapted to the various groups in the study. And it was structured around memory enhancement, memory health. It was framed within memory self-efficacy theory and focused on memory self-efficacy beliefs. and teaching internal and external memory training strategies. And the results showed that African-American and Hispanic participants showed larger training-related improvements on some cognitive measures, such as visual memory, than on other cognitive measures, such as verbal memory. But it's important to point out that there was considerable variability, not only across groups, but also within groups. So one of the takeaways here is that we can't simply collapse across groups when we try to interpret the results of these studies.
Muted, we're all muted. George, I think you've just muted yourself and we can't hear you anymore.
Oh, sorry, I'm not sure how that happened.
Yeah, I'm not entirely sure either. Yes,
okay.
Thank you.
Okay, sorry. Yeah, as I was saying, we're looking at the evidence now for cognitive training benefits with older adults, and there is really kind of a mixed picture here. Some meta-analyses support the benefit of cognitive training and the potential to improve other dimensions of health and well-being, but other meta-analyses conclude that there are insufficient data to conclude that cognitive training is efficacious for older adults. And one of the most influential reports was done by the National Academy of Sciences, and this was commissioned by the National Institute on Aging. And after a comprehensive review of the literature, they found beneficial effects of 3 classes of interventions, one being cognitive training, second, blood pressure management, particularly in midlife. And of course, this is very important in terms of some of the disparities we've talked about in terms of blood pressure, and then increasing physical activity. And one of the major conclusions from this report that there is moderate strength evidence for cognitive training based largely on this ACTIVE trial. So let's review the evidence from the ACTIVE trial. ACTIVE is an acronym that stands for Advanced Cognitive Training for Independent and Vital Elderly. It was co-funded by the National Institute on Aging and the National Institute of Nursing Research. It was and still is the largest cognitive training trial ever been done, over 2,800 adults age 65 plus across 6 different sites listed here. I was the site PI at the Johns Hopkins site. And ACTIVE posed the question does intervening on basic cognitive abilities transfer to real-world tasks? And the participants were randomized into 1 of 4 conditions: memory training, reasoning, speed, or no contact control. And then there were multiple follow-ups through 10 years post-training, and half the individuals who had gone through the initial training were randomized to a booster training or refresher training 1 year and 3 years post the initial training. I might also add that we have been funded by the NIA to do a 20-year follow-up of the ACTIVE trial, linking ACTIVE data collected through year 10 to large secondary data sources like CMS claims records and National Death Index. And we've also received a supplement, administrative supplement from the NIA to look at the associations of race and social determinants of health and long-term benefit of cognitive training. And we are working on a special issue supplement for the Journal of Aging and Health on that topic. On the right-hand side of the slide here, you can see the baseline characteristics of the sample. These were all community-dwelling older adults who tested normal at baseline on a cognitive status measure, and notably 26% of the sample was African-American, which is the largest representation of African-American in any cognitive training study to date. There, as I said, were 3 interventions: a memory intervention that focused on verbal episodic memory, which we know is very age sensitive. This intervention taught mnemonic strategies for remembering things like word list and main ideas in paragraphs or stories. There was a reasoning intervention that focused on ability to solve problems following a serial pattern. and practicing strategies on complex reasoning tasks, as well as reasoning problems related to activities of daily living. So, for example, filling out a medication schedule for a hypothetical patient who is taking multiple medications at different times, day and night, across the week. And then finally, a computerized intervention. This was also done in a small group setting with testing for training visual search skills and ability to identify and locate visual information under divided attention conditions. I wanted to share the 10-year outcomes with you for the cognitive training. We found that the effects persisted and were significant for the reasoning training and speed training relative to the other to the control group and the non-trained groups. And even though there was an overall downward trend in terms of cognitive function, reasoning and speed had a protective effect on cognitive decline over this 10-year period. Memory trended statistically in the same direction, but it was non-significant. Importantly, there were significant FAR transfer effects or generalization effects to IADL difficulty for all three intervention groups. So people in the intervention condition reported less difficulty carrying out everyday life activities like managing their medications or managing their finances. And then we did a preliminary study at 10 years looking at the impact of intervention on dementia. ACTA was not set up necessarily as a dementia prevention trial, but we did derive an algorithmic definition of dementia, and it was reported that the speed intervention was associated with 29% reduced risk of dementia over 10 years. And there was a dose response effect here in that people who had gotten the booster training had an even higher reduced risk of dementia. We're trying to replicate these results now with CMS claims-based diagnoses of dementia at 20 years. Now, ACTIVE is an example of a unimodal intervention in that it targets a single mechanism. So unimodal interventions attempt to make causal inferences about the ways in which improving particular skills transfer to everyday function. But more and more, we are taking a multimodal approach targeting multiple mechanisms. And the goal here is to investigate synergies among components and or make causal inferences that broad-based improvement in cognitive health can be engendered by what we do. So in terms of multimodal interventions, there are a wide variety of these types of interventions. I've divided them here into componential interventions and immersive experience interventions. An example of a componential intervention is the well-known FINGER trial, the Finnish geriatric intervention study to prevent cognitive impairment and disability, which I'm sure most of you have heard about. This involved diet and exercise intervention, monitoring vascular risk factors, and as well as cognitive training. And it found that there was a significant reduction in the risk of cognitive decline amongst those who participated in this intervention. There are also what I label here immersive experience interventions, which are more immersive learning experiences. And some examples here are Experience Core, Denise Park's Synapse program, and Liz Stein-Morrow's Senior Odyssey program. And the one I want to say a few words about is the Experience Core. This is part of a national program that involves placing older adult volunteers in elementary school classrooms. And here is a picture of one of our volunteers in Baltimore City working with a third grade class. And you can just see the excitement and engagement here of both the volunteer as well as the young children as they take part in this reading activity. Now, we carried out a an RCT of the Baltimore Experience Corps program that was funded by the NIA, and we randomized over 700 older individuals either to the Experience Corps program or a low activity control, 90% of whom were more than 90% of whom were African American. And this was really high intensity service. Volunteers spent 15 plus hours a week over 2 full school years. And then we looked at a variety of different outcomes, physical, cognitive, and psychosocial outcomes. And nested within this, trial was this nested brain health sub-study that was led by Michelle Carlson that examined intermediate neurocognitive changes in executive function and CNS integrity. And one of the questions in this this sub-study was, does Experience Corps tend to lead to changes in brain health, looking at hippocampal and cortical volumes? And what you see here on the left is that the men in Experience Corps showed a significant increase in total cortical and hippocampal brain volumes versus a decline in controls over this 2-year period. The women volunteers in Experience Corps showed the same trends, but the gains were more modest. And I think this is a nice example of the neuroplasticity that Octavio was mentioning in his talk. On the right side here of the slide, you see that the scores on the Ray auditory verbal learning test were correlated with the 2-year improvement in brain volume shown here in the blue. Let me finish by talking about a few future directions for this work. We still have this question of, do cognitive interventions work with older adults? And I think the simple answer to this question is yes. There are numerous research trials that show immediate benefit, including the ones that I've talked about today. But there are questions that remain about the practical implication and the practical impact of benefits on everyday life tasks, such as medication management, health and financial decision-making. How long do these effects last? And long-term sustainability and accessibility. And then other key questions: do these interventions have the potential to prevent Alzheimer's disease or to help dementia patients? So a few recommended future directions. We need a lot more work on dosage effects and adherence effects, because dosage matters. And a lot of these intervention studies are badly underdosed. We need more work on differential transfer effects across the individual domains of cognitive function. We certainly need more longitudinal follow-up studies on long-term maintenance effects. I mentioned the active 20-year follow-up study, which we are currently conducting. We've also received funding from the National Institute on Aging for a 12-year follow-up of the Baltimore Experience Corps trial. And this is kind of a parallel study, parallel follow-up to the active follow-up. We need continued work on multimodal interventions for cognitive decline among diverse at-risk older adults, greater use of computerized and iPhone training modalities, but also being mindful of concerns about sensory handicaps, about technical literacy, about affordability and accessibility of these different interventions. And then we need more work on brain scans and other biomarkers in the assessment of cognitive training and cognitive engagement effects. And there's work going on in this area right now. Sylvie Belleville's study is one of the key studies being conducted in that area. And so I'd like to close with many, many thanks to my collaborators. And also thank you for listening today. And if you would like any more information about any of the work that I've reported today, please feel free to email me or call me, and my contact information is shown here in the slide. Thanks again.
Our next speaker is Carl Kokendorfer from the University of Illinois at Chicago, and he will be addressing how an academic center is utilizing digital health.
Oh, no worries. I don't really know. Is there anything that you need to see on the screen? Like side notes on the. Okay. Make sure I've got another thing. Why? Oh, here we go. So you just press and arrow to go to the next slide.
All right, well, thank you for the opportunity to be here today. Very excited to share with you how our academic medical center, that's just a couple of blocks from here, has been utilizing digital health, especially over the pandemic, to positively impact our aging Latino community. I'm Carl Kokendorfer. I serve in our Vice Chancellor for Health Affairs office that oversees the 7 health science colleges. I serve as our Chief Health Information Officer. I have a role in the hospital as the Associate Chief Medical Officer, and I'm a practicing family physician, do in-person and telehealth visits at our University Village Clinic, about 2 miles from here. I don't have any personal conflicts of interest related to the contents of this talk. Just to give you a little bit more context to our medical center, we do the typical education, research, and clinical care. We've now expanded our federally qualified health center. I just heard yesterday, we now have 14 clinic locations, 465-bed tertiary hospital, just a couple blocks from here. We have campuses across Illinois in Chicago, Peoria, Quad Cities, Rockford, Springfield, Urbana. As I said, we have 7 health science colleges, include where I'm at, College of Medicine, but also nursing, pharmacy, School of Public Health, Applied Health Sciences, where we also have our biomedical health information science department, or informatics, where I work closely with, dentistry, social work as well. So about 1 in 3 physicians in Illinois are actually trained at our organization. 1 in 4 social workers are trained and have about a $243 million in research funding. So what I wanted to share with you today is some even basics of how do we even understand who our Latino community is, how do we do that through improved data visualization, how, there's been an expansion of telehealth visits, obviously with COVID, and we're hoping that that will continue. So we're still awaiting CMS to put in place some long-term funding for that. We expect that to happen. It's really important for patients to engage with their clinician. A lot of times we like to do that through, when they're not in the clinic, through their patient portal. We have a large system. We had one for 25 years, an EHR system for electronic health record system that our patients connected to. We've moved to a new one that has the largest share. So you may have used it yourself, a portal called MyChart. We've also tried through grant funding to get, how do we measure where our patients are at through patient-reported outcomes, or PROs, and how do we embed that into our electronic health record system. So we got some grant funding to do that. And then how are we addressing the digital divide? And we did that through an extension of our home visit program. So I'll talk briefly about all of these. And then in the future, how can we engage our patients more that we're noticing and recognizing as not able to connect up to us digitally for visits, for seeing their own records, to message us, and see in any other way that we need to connect with them. And so we're working with our engineering colleagues in Urbana-Champaign and the Mayo Clinic to try to do some more predictive work to identify who might be at most risk for things like Alzheimer's and other dementias. So a very basic thing, when we went live now 2 years ago, I was a little shocked when I asked for data on who are our patients. And so we have a race and ethnicity field, like everyone else that's rolled out these electronic health record systems. But within minutes, I can't really even see what percentage are Hispanic, which percentage are Black or African American. The data is, because they're separate fields, I have to sit there and add up like 1.3% in this category and 2.4% in that category. And I'm like, this seems bananas that I can't actually just do a simple calculation of who's in our clinic. And if we're really trying to empower people, look at the disparities that exist, we really need to make this easy. And unfortunately, the foundation system, the basic system doesn't make this easy for you. So I asked our team, can we actually do our own grouping just to simplify, how does the New York Times, how does the Chicago Department of Public Health display this information so easily on their cover of their newspaper and on their websites to say, look, you've got 25% Hispanic community, or you've got 50% of our Black community has not gotten the vaccine, or whatever the data is. Why is it so simple for them, yet we're not making it simple? So I've talked to our vendor about doing this, to embed it, and they still don't do it to this day. So we just did it on our own to basically group our race and ethnicity grouping so that anyone in the organization within seconds can be running their own reports. And so we were able to identify that in our summer clinics that we're about a third Black, non-Latinx. So that was a big part of it. Is I reached out to our Institute for Minority Health Research to say, hey, how should we be viewing this data? How do we classify something so simple and basic? And they said, well, the majority of groups do it as you display your Hispanic community numbers, but then it's your Black non-Hispanic, your Asian non-Hispanic, your white non-Hispanic. And so that's what we did. And so now I can easily see that we've got about a 26% Hispanic Latinx patient population that we're caring for. But the other key thing is when we first started doing this, about a third were other, that the patients weren't identifying, or somebody never asked them. And I'm like, well, again, we're not really understanding who our patients are and how do we do that. So we made very concerted efforts to just collect that data from our patients. And if you reach out to many of the health systems across the country, many of them still struggle with this problem when they were trying to see how the pandemic was impacting their patient population. As you can see, we still have about 8% that are in this other category that we're still working on trying to make sure patients feel comfortable, that we're using this data appropriately, and that we think it makes a difference. So as we know, with the pandemic, telehealth has expanded. And as you can see, it was pretty marked because we were able to get reimbursed for this type of visits, where before it was very difficult to get reimbursed for any telehealth visits. So when the pandemic hit, the number of telehealth visits skyrocketed, leveled off, reduced, and started to level off. But again, it's very important for us to be able to offer this. And so we're still hoping that the government will allow this to continue through CMS. But this also made us recognize, well, let's look at our patients that are actually connecting up to these portals and who are they? And as you can see, in our primary care clinics, we've got a huge discrepancy from 70% in our Latinx community up to 88 to 93% in our white and Asian community. So we've still got a ways to go, but we're now finally measuring this. And as you can see, the red numbers on this many have been invited to actually connect, but there's this digital divide that they don't have that extra little help to make it work. And so that's what we're trying to see how we can address those disparities. And as I mentioned, because we really want to be able to ask them important and relevant questions. If we're trying to understand what their cognitive function is, yes, we can try to do it in clinic, but as a primary care doc, I've got very little time to be able to administer additional metrics and tools. And anytime I'm part of grants and other activities, I try to do these things. But we looked at what are the neurological questionnaires that are actually available in this largest electronic health record system that has a majority of the market share in the country. And none of them actually had cognitive function available. We work with Northwestern and about 7 other institutions, health systems around the country, including Harvard and others, to how there are these tools called patient-reported outcomes to actually calculate ways to measure the patient's function and abilities in a much more robust way. And so there are tools like cognitive function short forms and things like that could be easy for us to deliver to the patients through this. We actually had to spend a lot of time and energy of how do we deploy these? What does it take to actually get this to work? Not only the technology, but the adoption by the health centers, by the technology teams that are quite busy frequently to be able to deploy new forms and tools into the system. So we definitely have been learning how to make some of these things happen. We've gotten some publications out there of how to implement some of these things into electronic health records. But we recognize that you really need strong clinical champions for this. We reach out to the memory clinic, and if they're not ready to engage and do this, then we're not going to have a lot of success. Making sure that we've got alignment with our IT groups to make it happen. And a lot of these tools were displaying information as T-scores. And clinicians, there might be 1 or 2 tests that we do that actually display information as T-scores. It's fairly foreign for the clinicians. And so until either we've got to do better visualization of the data, or we've got to teach them on how to interpret this and get it engaged. So still a lot of work to be done, but we're trying to advance that area. Because as you can see, there is a digital divide, and there is in our aging population, both on what our seniors are able to do and what they're interested in doing. So with the aging population, decreased know-how and decreased interest in some of these capabilities. But we know and think that this can really help with their engagement and ability to have better health. So when the pandemic hit, I struggled with some of my patients to be able to do telehealth visits or even phone visits with them. Some of our most vulnerable patients were those that were enrolled in our home visit program. They are typically the patients, we have over 100 patients that can't make it to the clinic. And so when they can't make it to the clinic, we're able to have some of our physicians go out to see them, or some of our nurse practitioners go out to see them on a regular basis. We try to shoot for at least once a month, and more if they need to be seen more often. But with the pandemic, they weren't able to connect. We were also being extra cautious of, didn't want to bring COVID to them or have any of our clinicians get COVID either. So we really wanted to make sure that we could do some remote patient monitoring, that we really could connect with them, get their devices to be able to work. So we partnered with a company to actually deploy some of these blood pressure cuffs, get them some technology in the home, even Wi-Fi, internet access if they didn't have it, so that in hotspots, so that we could actually be connecting with them still at the height of the pandemic. And it was really good to do that. Now, the other piece is that was only 100 patients in our home visit program. There's tens of thousands or hundreds of thousands of patients that we still need to reach. And as you saw, there's some health disparities in that. At a national informatics conference that we were at a few years ago, we saw that Oxnard Health System had taken the model of the Apple Genius Bar and had deployed them inside their clinics. They were calling it their O-Bar, so that patients, when they were coming to the doctors, that they could actually spend some time, because I've got about 92% of my patients signed up for a portal, but that last 8%, they're just struggling. And I try to work with them in the clinic, but I don't have the time to do it. So I really need somebody to kind of come alongside them. And so while they're on their way to the clinic or after the clinic visit, that they can stop by this physical presence. We're opening our first one at our Miles Square Health Center, federally qualified health system, where we're going to have a physical location that the patients can stop by, bring their devices. We'll give them some of the additional devices so that we can do more chronic care management remotely for the patients. But we're very excited about this. We've gotten a couple seed funding opportunities to help us deploy this and really be a way to help the patients get applications that we think can help their overall health and get them the devices, because a lot of this stuff, once it's configured and set up, it can be very automatic, where as soon as they take a blood pressure, it comes into our electronic health record. We can be alerted if things are out of the norm. And so again, we're looking forward to doing that. One of the other future areas is some of our colleagues at UC Engineering had been working with the Mayo Clinic and put a publication out there in Nature Scientific Reports about trying to do some early predictions for the patients that might have mild cognitive impairment or advancing to Alzheimer's disease using imaging and genomics. And we're trying to bring in our more diverse patient population to this mix, and also try to bring in some more of the electronic health record data that exists to be able to do some of this work. So very much looking forward to trying to expand some of this exciting work around AI and machine learning to do better predictions. So that's all I had to share today. There's a lot of great people that have helped, from my informatics team to our Blue Cross Blue Shield Health Equity data team, because we've gotten some funding from Blue Cross Blue Shield to look at our own health disparities. We've have a lot of great folks leading our home visit program, and now a new group leading our UI Health Lounge or Health Bar, our patient reported outcomes research team, and our partners down in Urbana with the Center for Computational and Biomedical and Genomic Medicine Center. So there's my email address, and I really appreciate your time for me to be able to share a little bit of what we're trying to do here.
Okay, thank you, everybody. My name is David Marquez, a professor at UIC and with the Rush Alzheimer's Disease Center. I'm going to give a few comments about each of the talk and then some overarching thoughts. And then we'll ask the speakers to come up for a short Q&A with the understanding that lunch is next. So you're like, all right, dude, come on, let's move on with this. So first we had Dr. Adhere, where she mentioned increased risk of chronic disease and Alzheimer's disease and related dementias, and really that multi-domain interventions might be the best way to go to simultaneously work with people to provide optimal benefits. But she pointed out that very little is known about culturally relevant foods and lifestyles within the Mediterranean-like diet patterns. One of the things that stood out to me is that 60% of the sample had less than a high school education. And this struck with me because we know we've talked about different SES levels within Latinos, but then compared to other races and ethnicities. And I was in a talk talking to people recently. They were saying like, oh, but we need to compare what Latinos are like to other races and ethnicities. And I see where the comparison is at times useful, but I'm one of those people who really pushes for, we don't need to be compared to anybody, right? Let's find out what are Latinos like, what are descriptives of us, because if you're trying to match on education or income or something like that, then that might not be representative of our overall Latino population. So that's something to keep in mind. And really with her findings and her work, stay tuned for this work that's going on that we I work on with her a little bit. She mentioned the food frequency questionnaires, and there's not always culturally relevant items that are included in there. So you can talk to her about some of the work that she's doing with the Rush Alzheimer's Disease Center with that, and her work combining the dance program and the mind diet is really innovative. I am actually not aware of anything like that with older Latinos. Dr. Acevedo and Moise in place for Dr. Rogers. We're really talking about technology and the life home. That's just an incredible simulation of a real home, and cutting edge video and audio software suite, smart technologies, spaces for data collection. And they talk about it in the context of successful aging. Some of the things that stood out to me with the robots too, what do robots need to do? Show emotions, be trustworthy, and provide social support. I mean, this is, there's the practical things about them that are going to be useful, but those that we think of maybe as like truly human parts that robots can or will be able to do are so important. I think also, with Latinos specifically, I was going to say the importance of usually interpersonal relationships. We know that maintaining one's independence in life is so important. And so these types of devices and technologies can help us do these types of things. It really stood out to me, the older adult perspectives as well, that it's not just healthcare providers, it's the people that are going to be using them what is the feedback and input of them? So I feel like this future work is really exciting, both scientifically and practically for society. One of the things that Dr. Reebok pointed out that I heard yesterday as well is about dementia being a feared aspect of growing older. You know, he reported the second most feared aspect. I've heard other surveys, seen other surveys as well that say it's the most feared aspect. And so Latinos are very open to cognitive training. He reported that Latinos had more than all the other ethnic and racial groups, that adding more mentally stimulating activities to one's life will improve all aspects of health, including brain health. However, there was only one large-scale study that included Latinos, the McDougall study, and that had a 2010 reference. So, you know, that's aging in and of itself a little bit right now. They've done, he and his colleagues have done tremendous work with including African Americans into the samples. And one of my main points will be about Latinos from the start, right? Having Latinos involved from the start. And then Dr. Korkendorfer talked about UI health right here. Like I should have had a disclosures like Miguel yesterday, trying not to be biased. You know, he put that in his disclosure about being bilingual. For me, I'm part of UIC, so I have this bias. So I'm quite proud of UI Health, and with about more than a quarter of our patients identifying as Latino or Hispanic or Latinx. Latinos were less likely to use my chart relative to other races and ethnicities. And then to say, okay, that's not okay. What can we do to close this gap, or at least so that Latinos, right, the usage increases? And so working to overcome the barriers, especially across older ages, because of the digital divide that he had noted. And the remote patient monitoring, partnering with them, where patients can check blood pressure, oxygen levels, and have them reported back to the clinical team through the use of technology is phenomenal. And then the ongoing and continued work with Alzheimer's disease in mind. So a few points just to make that I hope you will think about. In considering successful and healthy aging, is it the same for Latinos compared to other ethnic and racial groups? Now, I understand that I just said we don't need to make comparisons, right? So, but this is the successful aging for Latinos isn't necessarily the same. So to what extent do cultural values? You know, we know that there are many cultural values. The one that's been mentioned the past couple of days, familismo. And how does that factor into perceptions of successful aging? Maybe enhanced, maybe decreased perceptions. So these are relationships that I think need to be explored. And there is a clear need to include Latinos in the development of programs. I mean, I'm guilty of it at times with my own research, but we have to really do our best to say, well, in the next grant, we'll include Latinos in this work, right? Like, no, let's get it from the start. Let's advocate. We've got each other as colleagues. We've got our colleagues around the country that can really be co-investigators, collaborators. When groups don't have expertise necessarily, if it's interventions in recruitment and retention of Latinos, then reach out to the experts that do, because that grant might never come, right? And we can't assume that, you know, for example, in a smart house, how the people that are there are being involved in interacting with it is the way that all populations are going to interact with that environment. And in the technological advancements, one of the things I think about, how when they do become practical and hopefully widespread, are they available to people of low and high socioeconomic status? Right? Are they available to people whose first language is not English? Maybe it's Spanish. So those types of things for us to consider. So will they meet the needs of all people? Because that's what we're all individuals. We are people who are, in general, for the most part, trying to improve our health. So thank you for letting me make those comments. And if the speakers can come up for a question and answer session.
I'm going to start my question as the speakers come up. Mine is actually directed at Dr. Kokendorf. I thought a lot about this use of the my chart and how differential it is across race and also probably across age, and wondered as a Hispanic physician who spends a lot of time calling my patients, because I know even if they can access my chart, they can't read what's written in English. Which compared to my fellow physicians has created an additional burden for me, as most of my patients are Spanish speaking. So I spend a lot more time outside of the hospital calling my patients back. I wondered, however, whether there is some reticence again amongst Black and Hispanic physicians to use the EMR for that reason, knowing that their patients probably don't have access, or if they do have access, can't read what's written. And whether that's been studied, and then what the differential burden is for physicians of color who care, and we know that they do, predominantly for populations who are underserved.
Thank you, great question. Yeah, I wish it had been studied. I'm not aware of that capabilities. I do know that through the portal we can send some patient instructions in Spanish and it's at least 10 languages that they've got. But a lot of work is still needed to study this and to, as you said, it's a burden for the clinician, and many clinicians are already feeling overburdened and close to burnout. And so I think lots of opportunity for us to do this. And I think right now, we're still trying to get some of the basics of where are the disparities, and now I feel like we can measure it. It's electronic health record for 25 years, and now we're finally actually measuring some of the basics. So I think lots of work to be done.
If you have a question, if you don't mind coming on up to speak, so you can speak it into the microphone so Dr. Reback can hear you as well. It's lunchtime. I'm sensing the hunger. Oh, sure. Yeah, that's okay. So thank you, Flavia. If you don't mind responding to some of my thoughts that I had put out there, agreement, disagreement.
Dr. Marquez?
Yes.
Yeah, this is George. I really appreciated your comments. I thought they were great comments. I just had two reactions. One, I'm in complete agreement with you in terms of involving Latinos from the start in terms of these intervention studies. And I should mention that Jerry Edwards has received funding from the NIA for a trial called PACT, P-A-C-T, for preventing Alzheimer's disease through cognitive training. And that's going to be using a much larger sample than the active sample. And it's also going to have a much larger proportion of Hispanic Latino participants in that study. So that's just getting underway right now. And the second comment I wanted to make had to do with your advice to avoid comparisons. Again, I completely agree with you. I think we need to pay much more attention to within group variability and moderators of effect, whether it's socioeconomic status or education or other factors that may moderate responses to these interventions, and sort of really pay more attention to that, since we know there's a great deal of variability within groups, not even more variability sometimes than between groups. And I know Keith Whitfield has written a lot about doing these kind of within group analyses, and I think that's really the way to go, as you pointed out. Thank you.
Thank you so much. The first, but you were breaking up for a part. We caught the majority of it. The PACT grant, I missed, or we might have all missed. Who was the investigator leading that?
Jerry Edwards. She's at University of South Florida. This is a multi-site trial. Dr. Edwards was part of our active trial. In fact, the results I reported on dementia risk reduction were from a paper that she led. And so that was finding that the speed of processing training was very powerful in terms of reducing dementia risk. And she's examining that further with a much larger and a much more diverse sample than we had in the active trial.
Great. Thank you for that information.
I also wanted to mention, in terms of including them from the very beginning, in terms of using CBPR, community-based participatory research approaches, where we're involving community members, community health workers from the inception of the study. I think that can make a tremendous difference as well.
I had a question for Dr. Aguinaga. I really, first off, I gotta say, I love the Loteria card. I thought that was the coolest thing. But you know, I think everybody in this room can identify with the fact that, you know, changing your diet is hard. And I think, you know, it's a really common experience to try and change your diet to some degree. You had some results about the effectiveness of the MIND diet in terms of improving cognition. Do you have any sort of preliminary or pilot data suggesting the efficacy of this intervention, of being able to actually get people to change their diet? I think it's a really, really hard behavioral intervention that I don't know how effective it is, especially in the Latino community.
Right, I agree. It's definitely very challenging, and with my current pilot, I mean, we're not only targeting one behavior, but we're targeting two, right? Physical activity and diet. But I think how we're framing it, we're not just saying adhere to the MIND diet, right? So we are providing very specific strategies. So we go through different food items every week, but we have them think about foods that they're already consuming, right? So if we want them to consume fish once a week, then, you know, we say, okay, what are the types of fish that you're already consuming, right? Maybe we're not promoting the consumption of salmon. If they want to, if they have access to it, great. But maybe tuna is something that is accessible to them. You know, they can make tostadas de atún, right, or something like that. Tuna tostadas. So we are framing it a little bit different, and I know in some of the comments that we've received already from the ongoing intervention is that they're like, whoa, this is actually pretty flexible. And I didn't realize I was already consuming a lot of these food items, right? Like increased consumption of whole grains. Well, guess what? Tortillas are a whole grain, right? Corn tortillas are a whole grain. So reframing it a little bit. So we're not asking them to eat, you know, bland chicken. If you want to eat pozole, green pozole that has chicken and that has leafy greens and other vegetables, I think it's reframing the context. So stay tuned. I mean, I don't know what our results will look like, but we are very
and also in addition, so a randomized control trial of the MIND diet has been recently completed. So Dr. Martha Claire Morris, who is from Rush, who developed the MIND diet, she passed away. And now the PI is Dr. Lisa Barnes, who works with the Rush Alzheimer's Disease Center. So it was a 3-year trial, which was an intervention to try to get people to change to more of a MIND diet with a pretty diverse sample. So I don't think anything is published yet on the findings, but that will be coming out soon, I would imagine.
I'm trying to comment a little bit on the challenge of researching with future prediction of technology in advance, right? So some of the reaction with physicians when you're adopting things like smartphone or robots, we had this idea that well, it won't be affordable for the current generation. That's also impressive how the time it takes to research and get published, how fast the technology cuts up to actually be adopted. Like it's not uncommon that older adults might not have the most current version of a smartphone, but as soon as their kids or grandkids replace it, anecdotally, I did that with my mom, right? My old versions are the current versions that my mom adopted. So the early adoption, I think, is challenging when we're thinking about a robot. It's almost like a science fiction type of research. But I don't know how many of you have like a robot cleaning machine, like a vacuum cleaner. And when the Rogers was researching, like at the beginning, we were thinking about, well, people are not going going to adopt those things at home. But now it's currently where we're seeing many of those places. So I think as a challenge of grants, you have a scope, what's you're trying to envision some of the future adoption. And I agree, as much as possible, we want to have as much concepts going and pass in the current grant, because we don't know if the future one is coming up. But I think part of the challenge is to also do that incrementally and test all things in one single grant. So I think it's that always an ethical conundrum as well, because you don't want to increase the disparity. And often when you do these interventions, you observe somewhat this hardening Matthew effect, right? You get the ones that already have more affordance and education condition are the ones that benefit the most in using technology. And I think that's a big risk when we're talking about vulnerable population, is to ensure they have education. And it was mentioned financial conditions, there's the whole structure. So to give one example, practical next RAM, that we try to address that, we're giving blood pressure cuffs to our participants, and it's conceptual, right? Ideally, you know, if that proves to be effective, then you have to solve, when it comes to be commercialized, they need to have the affordance to have a blood pressure cuff. Now it's electronic to ease the burden, it communicates directly with the app. But let's say you have an internet problem that just occurred here, right? In a hotel, we have a privileged environment. Imagine in a rural area. So we have a manual routes that participants could also input their value using the cuff that they are comfortable using it. They could do it manually. So part of that, when you're identifying the limitations within the community they're working with, you also force it to think about those alternative routes. Like, how about if this doesn't work out? What can they do to continue using, if it's an application, if it's a website, or whatever modality? But that's,
you know, and that got me to think about technology in the form of TVs, right? When you first saw your first flat screen TV, right? It was like, oh my, you know, there were thousands of dollars. And now, I don't know if you looked at one of the other tube TVs recently, you're like, I can't believe I used to watch that. And like everybody has the tablets, right? Tablets are relatively affordable now. Maybe not an iPad, right? But you can get tablets. So the technology advances and becomes cheaper so that more people can be involved.
Yeah. When we're interviewing our participants, we thought about, we want to add smartwatches because it's primarily a mobile app. Some participants are ahead of us saying, oh, you don't have this on the watch. I want to like take my meditation on the watch. You know, we have to like have the same kind of design, so you're not giving watch to everybody. But it's interesting. Sometimes they're ahead of us.
Please join me in giving a big round of applause to this incredible panel. And maybe we can all meet up here for pictures while everyone else gets.
Everyone else can join the left or food. And stick around because we have a consensus building session about to start. So,
Hi, everyone. Feel free to grab a lunch, and then we're going to start the consensus building session in a few minutes. We're going to put different numbers on the tables, and they correspond. They have a different topic. So make sure you sit at the table of the topic you want to talk about. Thanks. Thank you, George.
You're quite welcome. I enjoyed it.
Thank you.
All right. I'm signing off. Bye-bye.
No, the program officer. And what's his first name? Oh, do we have someone else? Who said it first? Well, there you go. There you go. Thank you so much. All right, we're on a roll here and to keep the spirit going. Today is Friday, TGIF. What is today's date? It's a two-part question. What is today's date and why is it so special? Okay, we got one right here. There you go. This is like also a memory test because we had a part of that question yesterday. Just testing here, we've learned a lot. And then finally, we need to know whose birthday is close to this September 16th. What's your date? Today's birthday? Okay, 21st, anybody? One more time? 21st too? 12. 12. Okay, 12. Then congratulations, everybody. A big shout out to Sunshine and Angela and all of the rapporteurs. You all are amazing. Thank you, thank you, thank you.
I'll give you a white.
All right, everyone. Like after a whole year of planning, right? Everything comes to an end. It's great pleasure to have had you here. I want to thank everyone that helped in the organization of this event, all the funders, everyone that worked so hard to have this come together, to have your faces, your enthusiasm, your intelligence, to solve so many problems that we have in society, right? And especially with Latinos. Thanks to everyone that came before this series that have done all the work so we could be here, right? As scholars and as colleagues. For me, it was like a journey to actually work on this conference. It really takes so many hours of your life, but it's like, I really hope that, it has been for a good purpose, that you have enjoyed being here. I enjoyed having you here and hosting you here in the beautiful city of Chicago. So as we move to the next year, right, I'm gonna invite Mariana to welcome you to the next installment.
This one? Good. Yeah.
So thank you, everyone. And as you can see in that slide, from all the organizers next year, I'm the only one here, so you're stuck with me saying what's going on. But so within this installment of the three, or this round of the ICA conferences for, actually it was one, I think, going to be 2021 and 22, I think, but of course everything got delayed. So next year the conference will be in Los Angeles, Emma Aguila, Eileen Crimmins at USC, myself remotely from Mexico, and Fernando Torres Gil, I think still at UCLA. So the conference is going to be, the dates, they're not that, but I think it's next year. I think it's the same for 14 and 15. Yeah, 14 and 15. It's always confusing with Thursday and Friday next year for these same dates. The venue is going to be at the Andrew Center Auditorium at USC Davis School of Gerontology. Thanks to Dr. Eileen Crimmins, who was able to get that. And also besides the NIA funding, of course, The other hosts who have also given either in-kind or monetary resources will be the USC RICMAR, the USC Davis School of Gerontology, of course, because we're going to do this, the venue is there, the USC Shepherd Center for Health Policy and Economics, and of course UCLA. So everyone, mark the date, as with Angela, but for other reasons, you'll be hearing from us there, mostly Emma and myself maybe, but you'll be hearing from all of us, and so see you next year, and thanks. I don't know if I forgot something.
We have save the date cards.
Oh, okay. I think they're on the back on the table.
And I just wanted to also add that Fernando Dorskill had emailed me a job announcement at USC, the preschool, no, not preschool, Luskin School of Public Policy in Social Work and Latinos. So for those of you who are interested, I'm going to be sending that out on the ICA listserv. And if you'd like to be added to the listserv, please let me know. And finally, we kindly complete these evaluations because they're extremely important for us internally. Bob Wallace will be providing an external review, but we need to summarize all this for NIA and our progress report, plus to improve next year. And then also, as just a reminder, to be aware that a survey is coming out with respect